Good morning, everybody. I think we're live. Hopefully everybody's hearing me. I am David Paul. I am the chair of the Delaware Healthy Mother-Infant Consortium, and I am joined by Susan Noyes, who's the co-chair, and I will introduce Lieutenant Governor Bethany Long in a minute. And so on behalf of the full Delaware Healthy Mother-Infant Consortium, I want to welcome you all to our 15th year of learning. I feel really positive about our progress over the last 15 years. You're going to hear a little bit more about our progress and data at the end of the day in some more granular detail. So hang in there for those people who really like data. We're also really proud today to debut our video, which is titled Her Story. You're going to see that in the middle of the day. We're also really excited about that. We all know that it's been a very difficult year for many of us, but I think we are now seeing the light at the end of the tunnel. And as I think about that, maybe that's a really important analogy for our work on infant mortality and equity, a challenge, getting better and looking to a bright future. 2 years ago when we met live, we had some really challenging conversations about race and racism. Since our last in-person meeting in 2019, we've really watched as the country has had many of the same or similar dialogues. So today, we will continue those conversations on race and racism, how those factors really impact maternal child health in Delaware and nationally. We're also going to learn today about cultural rigor, policy, community, and the importance of stories and storytelling. So I look forward to hearing all of the speakers today and interacting with all of you throughout the day. We'll be taking questions after each talk. You'll notice that there's a Q&A box in the lower right-hand corner of your screen, so feel free to submit questions, and we'll have hopefully 10 to 15 minutes after each talk to answer your questions. Just one or a few brief housekeeping items. We'll have 4 giveaways throughout the day. Beautiful Healthy Women, Healthy Baby t-shirts that are polo shirts that you see that a number of us are wearing. So you have to be present to win a shirt, and you have to be logged on. So even more incentive to stay close to your computer. You also notice today that we'll have a visual artist, Lauren Green from See in Colors, who will be scribing the summit live, and everybody will get a copy of that at the end of the day. And so we're really excited about that new feature. And so without further ado, I'd like to introduce our great ally and our great champion, Lieutenant Governor Bethany Long. Our Lieutenant Governor is a nurse by training. She's a great champion for children. She's a great champion for our cause. She's served on our consortium, and I couldn't imagine a better advocate in the state of Delaware. So welcome, Lieutenant Governor, and thank you.
Wow, thank you. Thank you so much, Dr. Paul. I really am so thrilled to be with you today. During this COVID pandemic, it has been really a challenge. And anytime I can come together with an incredible group and a board who's addressing the most essential population health statistic in our communities and our states and across the globe, infant mortality, I jump at it. And I hope you're enjoying a cup of coffee as Dr. Paul launched us. You're going to have a phenomenal day as I look at the agenda. And to the consortium members and to Susan and Dr. Paul and Leah behind the scenes, it takes a village, and together we are going to make that impact, and we have. Think about it. 15 years ago, we came together as a consortium, and during this time have really addressed infant mortality. We have a lot of room to grow. We have a lot of areas to continue to improve. But if you think about it, the latest statistic, we're at 5.8 infant mortality rate per 1,000. That's better than it was when we started. The work really does matter. And I happen to be biased as a population health, public health nurse. I just love this year's theme. And I want you to think about that for a moment. To everyone who's waking up this morning, who's in the trenches every day, working with community, if you think about it, the power of you, the power of community, and shaping the narrative to really build healthy generations. It does start, one mother at a time, one community, a family. So your work is so incredibly valued and appreciated. I know many of you have had the opportunity to work with us with the Lieutenant Governor's Challenge, addressing physical and emotional well-being. Also, the whole issue around behavioral health. And as I look at your breakouts today, you've got some incredible experts in the whole narrative around community, around policy, around prevention, and particularly also around the key issue, as Dr. Paul talked about, disparities. I know Representative Mimi Minor-Brown is supercharged as she speaks today about her passion. We all gather to say, let's continue the dialogue, as Dr. Paul stated, about disparities among our communities of color. Think about it for a moment. I happen to have these statistics memorized, teaching population health and epidemiology at the University of Delaware. I really like to follow the numbers. And if you look at the numbers in Delaware, we have work. Right now, if you happen to be a woman of color, in particular, a Black female, you know that you are 1 in 4 in our state population size, but unfortunately, 50% of maternal deaths. We got some work to do. Also, with our young little infants, having been a NICU nurse back in the day and an OB nurse, we have room to grow. We recognize that, Black babies are 2.7 times, more likely to die before their first birthday than whites. So let's keep at it. Let's not let our foot up off the accelerator. It takes a village, our federal leadership, our state leadership in the community, and you in the front lines, our clinicians. But particularly, I just want to say, I'm excited. I know you've got a timetable. We've got to get going into our wonderful keynote this morning, who I know was with us in person in 2017. And I hope that next year we're gathered together again in person. So, throughout the summit, really look forward to the events. My team is going to be listening in all day. I'll be on and off, I'm sure, at different times. And again, thank you so much. And really, let's enjoy the day. And thank you to, again, Public Health, the team, and all of you, Dr. Paul, who are with the Delaware Healthy Mother and Infant Consortium. So I'm going to turn it back to you. Continue to be well, continue to do the things in COVID, and let's get vaccinated. All right, back to you.
Thank you so much, Lieutenant Governor. It's greatly appreciated your support, as I mentioned.
Welcome.
I am really happy to welcome Kay Johnson this morning for our first talk. Over the past 35 years, Kay Johnson has become nationally recognized for her work in maternal child health as an advocate, researcher, and consultant. Reducing the impact of poverty and racism and increasing access for women and children are two of her lifelong goals. Kay is president of the Johnson Group Consulting. Her expertise encompasses a wide range of issues. Her work at the Children's Defense Fund, March of Dimes, and George Washington University and the Johnson Group helped to shape the direction of maternal child health and Medicaid policy since 1984. Prior to her policy career, Kay worked with families in early care and education. As mentioned, she was here in 2017, and we're really happy to welcome her back. Kay, welcome, and can't wait to hear what you have to tell us.
Thanks so much, Dr. Paul. I'm really delighted to be here. I love doing this encore performance. Thanks to Susan Noyes and to Dr. Paul for thinking about me. And wonderful to see Lieutenant Governor Hall Long and her continuing commitment. I just have to say, you people in Delaware, keep sending us these powerful elected leaders and powerful women. You've sent us a first lady who's a teacher, and you have a lieutenant governor who's a nurse. I think that is just fantastic and creates amazing opportunities for us. I'm going to be sharing my slides and really talking to you about leadership for the next decade and how we can work on recovery, resilience, and respect. That's me over there in the right-hand corner, that little kid. That's me when I was about 3.5, going on 4. I call that collecting data at a young age. There I was with my pencil and paper, working out some problem, and I continue to do that in my life. And again, Thanks for inviting me back. I have often told the story about the wraps that we did on the pre-evening and about the wonderful way that you all engage community and leaders. So I'm just going to say a little bit about what I believe as I'm starting. I believe that equity depends upon strong and well-implemented public policies, that every person should have the freedom to decide if and when to be a parent and to raise a family, that reproductive justice will be attained when all people have the economic, social, and political power and the means to make decisions about their bodies, sexuality, health, and families. That clinical practice changes, QI, or individual behavior change are necessary but not sufficient to improve outcomes and end disparities. That to have equitable impact on the greatest number of women, children, and families, we must ensure effective public policies, programs, and services. And finally, as Nancy Krieger, who's a social epidemiologist, has often written, the data are not now, and they never have been neutral, and so we always need to challenge ourselves. I also wanted to talk about how I think of some of the common system failures. We're not assuring equitable access and equal treatment in our care. We're not directly addressing racism in our healthcare system. We often are blaming people and their behavior rather than on fixing the systems that fail them. We have primary care providers who are not yet sufficiently strong on preconception health and well woman care. In my view, as they were when I was a younger woman of reproductive age, they are still more likely to talk to her about her long-range cardiovascular risk than her aspirations and her reproductive life plan. That prenatal care quality receives too little emphasis. We decided that prenatal care alone was not sufficient. We needed preconception care, but we can't overlook the importance of prenatal care itself. That interconception care often devolves into LARC initiatives rather than looking at the whole woman. That we're preventing teen pregnancy, but we're not always preventing the weathering that occurs for young women, say between 15 and 25. We separate the head from the body. We don't address oral health and mental health. That topics such as perinatal HIV or opioid use are often marginalized and people stigmatized. The perinatal quality and the collaboratives that support it are mainly still about hospitals and vital statistics, and they're not about our larger systems of care or addressing equity. That home visiting is insufficient to affect the index birth outcome, and while it has great impact on family formation, family development, and child development, we need to be honest about its role with relationship to birth outcomes. And that social determinants of health are being assessed but not addressed. So just a couple of slides about, what data tell us about Delaware. These are some preconception characteristics from the PRAMS data that CDC offers to compare the states and the overall PRAMS. And what you can see is that in health coverage, you're above that national average. In the proportion of women who had a healthcare visit in the months before they got pregnant, I'd say that's just about at the national average. Those just differences probably aren't sufficient. That in Delaware and elsewhere, the percentage of women who report experience symptoms of depression before they got pregnant is running around 12%. That in terms of preconception vitamin use, you're a little bit behind the national average. And then in terms of attended pregnancies, again, about at the national average. But the thing I think is most important about this slide is, except for depression, we'd like all of those bars to be up around 90%. We've made so much progress on health coverage. Let's get those other things up at 90%. And then in terms of postpartum characteristics, again, the health coverage a little better than the national average, postpartum visits a little behind, again, similar on depression. That seems to be a constant rate among the average for women, although we know that in particular, low-income women may have rates of perinatal depression and depression overall that run double the average, so around 25%. And then in terms of postpartum contraceptive use, you're ahead of the national average. And then breastfeeding at 8 weeks, just a little bit behind. Just to give us a sense of altogether on a couple of pages where some of these trends are running for you. I said I was going to talk about recovery, resilience, and respect. And to me, this picture just screams recovery. You know, we all want to have our heads together. We all want to feel joy. We all want to be in a world where we can have fun and be with those we love and our friends. And so let's talk about how we can accelerate getting there. I think we all know that the COVID-19 emergency has disrupted the lives of virtually all children and families, with greater challenges among those already vulnerable. And this graph on the right is just one of many that illustrates this challenge. And it shows us that children in households of color are more likely to be experiencing food insufficiency during the COVID-19 emergency. These data are from February. They're February of this year. And what you can see is almost 30% of Black children and almost a quarter of Latinx children were experiencing food insufficiency compared to only about 10% of white children. I'm going to talk today a fair amount about the American Rescue Plan and how it helps us with our recovery. And this is just a little montage of various things. So you can see up here in the upper left, these are the items that my Senator Bernie Sanders highlighted in his social media promotion around the American Rescue Plan. And on the left, you can see a similar set of things that Fox News highlighted about Biden's rescue plan. You can see the promotion on the right from the White House about the American Rescue Plan. We cut child poverty in half, and we're going to talk more about that. And there's the president and the vice president at the signing of the legislation. The pie chart is from the Nonpartisan Congressional Budget Office, which is a research arm, of course, of Congress, and it really telling us where did the money go, the data. So in the biggest wedge, those $1,400 relief checks to families. Next largest wedge in that light kind of aqua is aid to state and local governments. And some of that is really going directly into public health agencies. The federal boost in unemployment insurance is the next largest wedge. This little salmon colored wedge is tax credits, direct assistance, and things like childcare for families. I'm going to give you a lot more details about what's in that $219 billion, as well as then reopening schools safely, vaccinations, and supporting direct health care, and some other things that mostly that have to do with business and recovery. Why am I talking to you about this? I'm talking to you about this because it's the biggest shift in child and family policy for many years. It's certainly the biggest shift since Clinton and Gingrich did welfare reform. It's likely the biggest shift since the Great Society and President Johnson 60 years ago. And many people are writing. I saw another really strong editorial opinion piece yesterday from an historian talking about how this really is as big as what Roosevelt did to help the nation recover from the Great Depression. So this is, for us, and it's a generational opportunity. And this is a shift toward policy designed to help a wider array of families than our policies often have. You don't have to be a single parent family. You don't have to be the poorest kind of family. This is designed to help recovery among all kinds of families, and I'm going to show you why. There's so many people whose lives have been disrupted, these children and families. So there's going to be immediate relief in terms of income, healthcare, childcare, nutrition, education, and mental health. It puts us on a pathway to end child poverty within a generation. I've been working in public health for more than 35 years. We often say in public health and maternal and child health, well, what can we do about poverty? Well, what we can do is the kind of policy that we enacted. The policy we enacted is for 1 year. If, and it's a big if, these policy changes can be made permanent, we can change the direction, the impact of poverty on these families for the generation. So this is the headline view of the American Rescue Plan, which is what the president proposed, and the American Rescue Plan Act, which is what Congress approved and the president signed into law. So I put it into 4 buckets. First, protecting the health and health coverage. So there are Medicaid protections, which we'll talk more about. Things like reducing the Affordable Care Act premiums, expanding the public health workforce, a safety net provider investments, and a science-based response to COVID, including the vaccines, with equity as a priority across all of those areas. There's a second bucket around economic relief to families with children, several kinds of tax credits, which we're going to talk a little bit more about, improvements in family leave, the relief checks, the unemployment benefits. The president proposed that the Congress did not enact the minimum wage change. And my understanding is that in Delaware with SB 15, it passed the Senate about a month ago, and it's pending in the House. And I hope that Governor Carney and your legislature figure out a way, a path forward to increase the minimum wage in Delaware. It looks like this is going to be left for the time being to state action, and it's exciting that you're engaged in that in your state. Assistance with basic needs, income cash assistance, childcare, utilities, food, home visiting support, and housing assistance, as well as things for opening education settings safely. And that goes from childcare stabilization to K through 12 schools, particularly those hardest hit, and an education fund, a challenge for equity for schools, and then relief in higher education. So it's really, all the way from birth through higher education, opportunities to reopen our education settings safely. This is your generic to-do list. I'm going to talk more about these things as we go along, but it does seem to me really critical that those of us who care about maternal and child health and families and public health really are active in the implementation of this new law. A lot of these changes are only for 1 year. A lot of the decisions are going to be made at the state level about how the money is spent. So finding out how the ARPA policy changes may affect your state and community. It might be following it in the news. It might be listening to reports from your governor, your agencies. Understanding how the changes affect programs and services for women, children, and families. We're going to talk more about that. Informing decision-making about implementation, letting your state lawmakers and your state executive branch leaders know about how decisions will affect the families that you care about or your lived experience. Training staff to help inform families, and then educating the people you serve about their opportunities, their rights, their benefits under this law. Connecting people to other resources. VITA is volunteer income tax advocates. So maybe you and your organization are not tax experts, but you could help connect families to volunteer income tax advocates who can help them understand how to use tax credits and other things. And using your coalition, your consortium, and your community partners to help inform and engage people in this larger discussion. So I'm going to go a little bit deeper into Medicaid and its role in improving the health of women and infants because it's so central to the work that we do. I think, as you know, Medicaid covers a disproportionate share of women in vulnerable populations, whether they're low income, single parents, they have less than a high school education, they're Black or Latina, and you can see the red line there, the national average. So disproportionately likely, particularly for women. Those are policy decisions that we've made over the course of the decades since 1965 when Medicaid was created. Medicaid is really important to millions of women of color. Nearly 1/3 of the people who are enrolled in Medicaid are African American. Over 1/4 are Latinas, and about 1 in 5 are Asian American and Pacific Islander women, particularly Southeast Asian and Pacific Islander women. Medicaid is a really important source of funding for family planning services and accounts for 75% of all public funds spent on contraceptive services and supplies. Many people think about our Title X programs or our other grant programs that directly support family planning clinics, and yet Medicaid is an essential source of financing for them and the people that they serve. And you can see there are many of the details, such as choice of provider and covering all the FDA-approved contraceptives. Medicaid is really important coverage for people who are childbearing, for pregnant people, for pregnant women. The prenatal services, you can see here, I'm just going to give you a guide to this. This is from a survey done by the Kaiser Family Foundation. If it's a bolded item, it's something that Delaware does. So everyone covers prenatal care, but only 35 states cover case management, and Delaware is among them. All states are required to cover smoking cessation during pregnancy, and all states cover the prenatal vitamins and prescriptions. Home visits there means not your home visiting program, but clinical home visits to support a woman during the prenatal period, genetic counseling, substance use treatment, several of those things optional, which Delaware has covered. At the time of birth, all states covering hospital birth, labor, delivery, and newborn care, but only 32 states are covering birth center deliveries, and you're among them. Only 3 states have picked up on Medicaid financing for doulas. And there's an opportunity for Delaware there. Childbirth and parenting education, not in every state, but in your state, and everyone's covering care for maternal or infant complications. In the postpartum and interconception care services, everyone's covering postpartum visits and family planning, but not everyone's covering, and you are, breastfeeding support, maternal depression services, those clinical home visits, and interconception care for higher risk women. I want to talk for a moment about the distinction that I'm making between postpartum care and interconception care. Some of you know that I was the co-chair of the National Preconception Health and Healthcare Initiative, and I ran the initiative under contract to CDC for its first 6 years. And we, as an expert panel, when we made our national recommendations, we made a distinction between preconception and interconception and postpartum services specifically. So I'm going to start on the interconception side to say that doesn't just mean the woman had a baby before. It's defined as aiming to provide women who had an adverse pregnancy outcome with care to reduce the risks that may affect the woman's health and any future birth she may choose to have. Interconception care models are like chronic care models with additional care coordination services and support. So think about like a diabetes or an asthma chronic care models. And one of my mentors and a leader in a longtime leader in maternal and child health who has left us, Dr. Lorraine Clairman, always reminded us almost all of the women in need of interconception care are already known to the medical care system, and that it's up to us to figure out how to deliver them those enhanced supports. We have a lot of emphasis right now on the postpartum period, and I'm going to talk more about that in a moment, but that figuring out how to increase the use of and the quality of postpartum care. These are recommendations from a CMS expert work group. The citations in my slides, which will be available to you. I was a member of this work group. And I think we really gave strong emphasis to expanding the postpartum coverage, particularly through Medicaid, increasing access to community support and care coordination, using managed care contract language as a leverage, and increasing quality. Specifically, this report mentions using more women-centered, team-based care and payment reforms, and it emphasizes measurement. And I like to emphasize, I think only Ohio is using the American College of Obstetrics and Gynecology, National Commission on Quality Assurance, and they've got these PCI recommendations. For postpartum, they say use a 4-part measure. Did the postpartum visit do maternal depression screening, engage women in the subject of breastfeeding, screen for diabetes, and engage women in the subject of contraceptive? They've made that Ohio has adopted this as a 4-part measure for Medicaid providers. They have to demonstrate and report that they've done all of that work. So it's just one way to both measure and boost the quality of those visits and make them more meaningful for women and get at some of the issues we really hope those visits will get at. So back to the American Rescue Plan Act, what did it do for Medicaid? Well, first and most important, it gave states the option to extend postpartum Medicaid and CHIP coverage. It also gave an additional incentive in matching FMAP is federal Medicaid percentage, and that's the matching rate. It's going to give another boost for the states who haven't adopted ACA for Medicaid. If they will do it, it'll give them a bonus. It did more continuation of the Medicaid coverage for COVID vaccines and treatment, and it also boosted the financing, federal financing for home and community-based services. So what's your to-do list in postpartum care would be to support Medicaid postpartum expansion in your state. And now's the time to begin to plan for that. Very exciting. HHS Secretary Becerra announced yesterday that Illinois' waiver is the first to be improved. This is an opportunity for states not to have to use those cumbersome waivers, but just to get a state plan amendment in Medicaid, plan to use the option, and secure the resources to do it, submit your plan, get approved, and start it early in 2022, which is when some of the COVID extensions will run out. Learning more about postpartum coverage loss among those you serve so you can document the need for this extension, and helping birthing people get timely postpartum care. We know for those who are low income and in Medicaid, the postpartum care utilization typically runs about 60%. So just to give a little flavor of new mothers losing postpartum coverage, these are older data, they're new data released in the past week in Health Affairs, but this really shows a similar pattern that most of the women, nearly half of the women who were uninsured as new mothers with a baby, lost Medicaid coverage postpartum. That was the reason that they were uninsured. Overall, half of the women who were uninsured were below poverty, half Latinas, 2/3 were citizens, more than half were married, and another quarter lived with a partner. And while 1/3 were employed, nearly 6 in 10 were not in the labor force. And we know that COVID-19 has made some of these losses more severe as people lost their jobs. Medicaid is equally important for babies, and the combination of Medicaid and CHIP, most CHIP-covered infants are in Medicaid programs effectively, but more than half of babies, we often hear that nearly half of all births are financed by Medicaid. I think that number is an underestimate. It's a little bit old. It's pre-Affordable Care Act, and really by 2018, more than half of all babies, 2.2 million infants of the less than 4 million babies that were born, were enrolled in Medicaid. And then if you look at the graph, you're seeing the impact for babies. So that 6 out of 10 Black, American Indian, Alaska Native, and Hispanic infants were enrolled in Medicaid. And over half of all Black, Native, and Hispanic children birth through 18 are enrolled in Medicaid. So what I've just been saying again and again, since these kind of data have started to come out in the past couple of years, is that if we care about equity, we have to care about the performance of Medicaid. We have to care about what Medicaid pays, who delivers services to these families and mothers and babies, and whether or not that's equal treatment, equitable access, and really performing at the highest quality. We can't get to equity if 60% of our babies of color are not getting quality care. I also released a report earlier this year about missing babies. The federal law guarantees automatic and continuous enrollment for every baby born with a Medicaid-financed birth. That Congress intended that they not have a break in their coverage from the day they were born through their first birthday, but too many babies are falling through the cracks. And so if you want, and my analysis indicates that this is an administrative issue and can be fixed. We have wide variation in the states. So if you want to work on this issue, your to-do list is to review the Missing Babies report or just the short executive summary, to check your own state website. I looked at all the state websites to figure out how are we communicating this to families. Sometimes it's only on the pregnancy page, not on the child health page. Sometimes it's not, this coverage guarantee is not visible at all on the state's website. So I encourage you to check your state's website and the provider guidance manuals. And if you're serving families around the time of birth, to inform them about automatic and continuous eligibility for their infants, make it be a routine part of how you inform families. And if you're a care coordinator or a health navigator or a home visitor or someone else who does that kind of work, a community health worker, help families confirm that their infant is enrolled. In most states, there's a phone number or a website or a means for the family to confirm that the baby has been enrolled. The Biden administration has other priorities in terms of health coverage, and they've issued executive orders, they've done agency action, and they've had these legislative proposals, as I mentioned. But one important one is the special enrollment period. It's got about 30 days left. In order to enable people affected by the COVID-19 emergency to enroll in those Affordable Care Act plans. The premiums have been reduced. Most of the premiums have been cut in half. So sometimes people think they can't afford it because the premiums are changing, they may now be able to afford it. So check out healthcare.gov or your state's insurance marketplace website. And if you go to healthcare.gov, you can get to the state insurance marketplace websites. Assess the need for coverage among the families you serve. Inform families about the special enrollment period, particularly in the next 30 days, and assist families with the online enrollment process. We know that the digital divide keeps families from being able to do certain kinds of enrollment or check on things that they could check on if they had better access to internet, broadband, and a computer. Let's talk a little bit about resilience. Resilience is a term it's very important in my life. It has been a very really central asset to me, facing a lot of challenges in my life, and I think for our whole country in this time, resilience has been really important. And in fact, I'm urging all of us to shift from our conversation about, oh, we're also down to, oh, let's draw on our resilience. Try to flip the script a little bit on this. And overall, thinking about how we're going to transform the culture of health and healthcare. This is from work that Paula Braithman did on social determinants of health for the Robert Wood Johnson Foundation. I really like the way that Braithman and her colleagues illustrate the social determinants of health. That, of course, this basis of health. On top of that, we know increasingly from science that health is forged through the interactions between our genes and our experiences. And so we used to ask the question about whether it was nature or nurture, and now science definitely tells us it's nature and nurture, and we need both. And yet in our work in healthcare, we are really often focused on people's individual behaviors or the medical care system. We know that's not all that's needed to improve health. And we're often focusing on behavioral issues when in fact there are larger social determinants that are driving health. So that the social determinants of health framework talks about the living and working conditions in homes and communities, and the economic and social opportunities and resources that people have. So if we start at the top, reducing poverty and segregation, eliminating racism, stimulating economic development in disadvantaged communities, promoting child and youth development through education, and all the way from infancy through college, and investing in job creation and training. Those are all things that affect people's health, well-being, and lives. And then in our creating safe and healthy homes and communities, neighborhoods, schools, workplaces, and having strong safety nets and social supports really influences health. And we have lots of studies now that show us. And then even in the context of our medical care, how do we transform to promote optimal health and development, to focus on both biomedical and social determinants, and to engage and respect families and their lived experience, and to use team-based care and high-performing medical homes, both for these women and the children that we care about. So I think policy plays a really important role in shifting social determinants of health. Sometimes we forget there are positive and negative social determinants of health, This figure at the right is from the social, it's an adaptation of the World Health Organization framework that talks about structural determinants in the social policy context with more opportunity and justice and income and intergenerational wealth. That intermediate determinants that have to do with material circumstances like living conditions and safety and well-being and family strengths and positive experiences, and those direct care determinants that we want to reduce unequal treatment and increase access to quality, comprehensive, team-based care. How can public investments help us get there? By eliminating child and family poverty and raising opportunities, providing for basic needs, supporting and strengthening families through the way that policies are designed, promoting positive experiences at home and in the communities, and improving health across the life course for women, children, and families as a result of strong investments. I'm going to go back to our American Rescue Plan and remind you that we've got these 4 buckets. I'm going to give greater emphasis to some than the others, just to give you a little flavor of these. So in that second bucket about tax and income supports for families, I really want to talk about the tax credits. The child tax credit is really important and has really changed. Previously, for both the earned income tax credit and the child tax credit, many poor families did not qualify for the tax credit because they didn't earn enough money and have enough income tax paid. These are now what is called fully refundable. That means even if you didn't pay in as much as the standard credit would give you back, you're getting the standard credit. The child and dependent care tax credit, as you may know, is very important for families who need child care and families who are paying for dependent care for a child with special health care needs, a senior living in the home, or others who need assistance. The federal support for unemployment benefits during this time of crisis, and it shifted tax credits for family leave. So in this area, your to-do list is to just get the basic understanding of the differences in these various tax credits, and I've given you some links that can help you do that. Inform families about tax credits opportunities and the family leave, and connecting families to medical legal partners, those volunteer income tax advocates, or other resources. I just want to go back and say the President and the Congress have structured this policy change so that families can start getting monthly payments around the child tax credit in July. They don't even have to wait until filing their taxes next year. We can start reducing family poverty with the child tax credit in July for many of the families that we see. The earned income tax credit, we didn't do this study on the child tax credit yet, but the earned income tax credit, we know, improves maternal and child health outcomes. I talked to you about this the last time I was there, that in some ways it shows outcomes in parallel to what we tout for our home visiting programs, and that it improves maternal and infant health outcomes, that there's better school performance for the children whose families are supported. And for those who had it when they were young, they're more likely to get to college, graduate from college, have good jobs, and have good earnings in the next generation. So we need to think about the earned income tax credit as being a parallel strategy in MCH to our home visiting work that can affect actually many more families. The American Rescue Plan Act also has emergency assistance through the relief checks and the unemployment, but also income assistance through the Temporary Assistance for Needy Families, TANF, food assistance with the boost in food stamps and WIC, and access to groceries to help replace school food, childcare subsidies, rental assistance, help with utilities, homeowner counseling, eviction protection. So these are concrete needs. You can help having staff trained to inform families and give families information about emergency assistance, confirm that families got their COVID relief check, and help families connect to the kind of assistance that we know for income, food, housing, and so on, and really using your community partners to help make these connections. Let's shift over to respect. It's so important for us in our society today to think about not only recovery and resilience, but also respect. I think this is a time to go farther, to do better. What we've been doing has been incremental and limited by our socio-political context. We've not been investing in whole families, sometimes in the mom, sometimes in the child, almost never in the father or the second parent. But this notion that investing in whole families improves things is really fundamental. Our policies have not been reflective of women's voices and lived experiences. We've not been acknowledging or addressing bias and racism in our policies, in our healthcare system, and we've not been sharing power with women, families, and communities. One of the ways that we can go farther on this is looking at things that have been recommended in Congress, like the Black Maternal Health Momnibus. And if you don't know, there's a tool in Congress where they put a lot of bills together. It's called an omnibus bill. I love the play on words to make it the momnibus. And you see your Congresswoman is among those who are part of this caucus and part of the support for the momnibus. We have all kinds of members of Congress who are doing this work. I'm showing you the momnibus components and some other bills that were in the last Congress, just to give you a flavor of the sense of the roundness of this work. It's not just about one thing. So if you look at the momnibus about addressing social determinants, protecting veteran mothers, looking at data and technology, looking at justice for incarcerated moms. All those are folded into, in the workforce, all those are folded into the momnibus. And then in the related legislation, several of these bills had to do with Medicaid, and I'll talk more about that in a moment. But then others had to do with quality, modernization, accountability, and other kinds of standards. So the topics across those bills introduced last session, I put into 3 buckets. One is coverage, having the postpartum coverage option for states. If a lot of states take the option, we can probably make this mandatory for the whole country. But we're going to need states to step up and apply for that option, getting ready now to do the planning for startup next year. Right now, this is a one-time, one-year opportunity. And we need incentives for extending that postpartum coverage, and the Congress has given us that, but only for 1 year. And thinking about innovative payment models, as some states are starting to do. There's a whole bucket of things that cross over several of these bills that have to do with perinatal quality and perinatal quality collaboratives, provider training, particularly related to bias, the expansion and diversification of the workforce for maternal health, having pregnancy medical homes and care coordination be better supported, data quality measures, and grants to states to implement best practices. The bundles of things that we know are evidence-based and really can help both inside healthcare systems and in the community. And there's a bucket of things that are related to social determinants of health. It creates an interagency task force that's very strong in its representation, and it asks for reports both from the National Academy of Sciences, the Government Accountability Office, and departments including HHS, Veterans Administration, the Department of Agriculture, Justice, and so on. And there is money in some of these bills that did not yet pass for community-based programs, for small community-based organizations that are serving traditionally underserved populations, that have expertise in serving particularly women of color that have not been previously supported in federal bills. I see the opportunity here to address unequal treatment, but that we really need layers of change. And the momnibus begins to get at some of these, but we need to go beyond just what we can do with policy. So improving coverage benefits and reducing costs for family is clearly critical. Addressing the role of racism and access to equitable care for Black, Indigenous, and other people of color is essential. Implementing our practice guidelines better is very important, and I'm going to talk more about that in a moment. Adopting anti-racist and anti-biased approaches in healthcare, and designing and conducting quality improvement efforts with a quality lens, with an equity lens, not just measuring disparities at the end. Too often our quality improvement efforts do something that's generic for the whole population, and then at the end, they measure disparities. We need more quality improvement that's focused specifically at eliminating those disparities and improving equity. So this graph is one of several that I have that comes from PRAM's data that gets at how we're not doing equitably implementing the guidelines that we have. So in this case, this is preconception or pre-pregnancy advice and services. So on the left side of the graph, did women receive advice on achieving or preventing pregnancy? So most of us in this meeting, we call this preconception health counseling, right? Look at those numbers. First of all, look at the scale of the whole thing, right? It's not even to 10%. And so we've got this, advice, just very low proportion. But then, even then, within that low proportion, Black women half as likely to get that kind of advice from their health provider. And then, did women report that they got medical services in the preconception period beyond that advice that were related to their preconception health? Look at the dramatic shift between the white women and the Black and Hispanic women. I have slides that show these kinds of disparities around breastfeeding counseling, around HIV screening and testing during the prenatal period, a whole series of things that are guidelines that are recommended for all and are not even being equitably distributed or done. So I'm going to go through a series of examples. I know it's a lot of lists. I'm going to go through them relatively quickly. They'll be here for you to think about, and when you look at my slides and think about as you go forward in your work. Obviously, adopting policies to shift social determinants of health and well-being, and I've talked about a lot of those. I'm so excited that we've got tax credits and better family leave, and more incentives for states that haven't done the Medicaid eligibility expansion for adult men and women living at 138% of poverty, and extending the Medicaid eligibility for 1 year postpartum now is an option. All three of those things addressed in the American Rescue Plan Act, with state action and local action to follow to implement those. And then getting things like the Momnibus bill or the Department of Health and Human Services plan enacted and fully realized to get federal agency policy activated, supporting our safety nets, and building our MCH workforce. These, what I call small p policy examples, are more related to administrative action. So I think this notion of building a workforce of community health workers, navigators, and doulas, and others who provide care coordination, particularly in the area of maternal and infant health or maternal and child health, is going to be really critical. We know that President Biden is strongly committed to creating a community health workforce, a public health workforce, a service workforce. We want MCH to be part of that. While we think that having a growing workforce of people who care for people in home or who work in nursing homes is important, we need that MCH workforce development as well. Incentivizing patient-centered team-based care in medical homes, and quality and well-woman visits. Having Medicaid interconception projects doesn't require any new authority or eligibility, just action and imagination in our states. Using managed care contract provisions, and as I mentioned, those perinatal quality collaborative work to advance equity in particular. Some program strategies that are related to changing the culture of health, to use the Robert Wood Johnson framing of it, to promote reproductive health and autonomy and build respectful and meaningful partnerships with families and communities. There are women now who are reporting in some webinars who say, home visiting sometimes starts to feel like policing. Did we get our family planning? Did we get the baby's well visit? Are we still breastfeeding? It's a checklist of did we, rather than asking us what we need, what kind of support do we need, and building a respectful and meaningful partnership. Using an equity lens to assess our public health policies, programs, and practices, and training the MCH workforce on root causes of inequity and anti-racism. Again, this point of shifting from monitoring behavior toward listening to and supporting women and families. I'm sure some of you are already practicing that. We need to build it into the program expectations. Adopting a state strategic plan aimed at birth equity, Michigan and North Carolina are two states that have been active in that area, and you've done a lot of work and you're on that road as well. Focusing on the social determinants of health and collecting our data and using it to understand variations by race, ethnicity, income, and insurance status. Some practice opportunities related to clinical action. I think operating under the medical home principles to deliver primary care that's patient-centered, comprehensive, team-based, accessible, coordinated, and committed to quality, safety, and equity. Those things were all in the original IOM definitions. The equity piece actually often got dropped, but we know how fundamental it is. And addressing structural barriers to care, including racism. And I love that ACOG put into recommendations to combat racism, racial bias, and achieve inclusiveness in our own professional settings. Building awareness of and seeking to remedy practitioner bias, and assisting in the recruitment and training of providers from racial ethnic groups that reflect the community served to create more cultural congruency, as well as engaging with others, building coalitions to work on issues of equity and social justice, as you've been doing in Delaware. So what do I see as big opportunities for Delaware? I see continued work on Black maternal health with broader representation and understanding of structural racism. I see you being among the first to adopt the Medicaid postpartum coverage option, where you start planning now for a startup in early 2022. I see the use of the American Rescue Plan Act to increase equity and address social determinants of health. You've been talking in your state about social determinants of health and their impact on maternal and infant health. How can we, in this 1 year opportunity, some of these things may go away in a year, how can we show their value and their impact and help families recover from COVID by getting them well implemented? Accelerating payment innovation is an area where you've been doing work and I think can go farther in terms of well woman care with priority on social determinants of health screenings and response. And to conduct training and quality improvement related to maternal mortality or morbidity, and including measurement, particularly through your perinatal quality improvement collaborative, and improving access to a continuum of quality services from preconception to 1 year postpartum. I think it's a huge opportunity for us to think about what would it mean if that half of babies whose births were financed through Medicaid, if all those moms and all those babies were covered for a whole year without interruption, how could we leverage that opportunity to improve their health and set them off on a healthy trajectory? You've got your Healthy Women, Healthy Babies 2.0 plus, and I see that as an opportunity for you to build on. So in my view, every Delawarean, in my view, I'm supporting Dr. Paul, I'm quoting him, every Delawarean has a role to play in decreasing the Black infant maternal mortality rate. And communities know best how to connect with and empower women to be healthy, to improve outcomes for moms and babies. The consortium has undertaken an aggressive initiative to examine the social determinants of health by taking a life course perspective and to both understanding and addressing the disparities that have led to the rise in Black maternal and infant mortality in Delaware. And I would just say to you, I think we all know that if we improve the quality of care, if we center equity, that we're going to improve the quality of care for all. If Medicaid services are better for in the prenatal period or the postpartum period or the early childhood services and primary care that we deliver, that's going to improve the quality of care for all mothers and babies and children. So we've got a huge opportunity in the American Rescue Plan Act. There'll probably be more money coming down the road for workforce and public health, but we've got to figure out how to take some of those investments and really leverage them into our maternal and infant health opportunities and needs. So Dr. Paul, I turn it back to you.
Thank you so much, Kay. That was a fascinating discussion and really helpful for our future work. So I really appreciate that. We have about 9 minutes for questions and a comment from our medical director of Medicaid. So I'll hold that for a little bit. But the first question from Christina Andrews, do you consider support of postpartum doulas in this postpartum and interconception care?
Absolutely. And it's something that certainly a lot of states are thinking about and a lot of communities are doing and investing in the role of doulas. We've not gotten huge traction with the Medicaid financing for doulas, but clearly that's an opportunity. I think the challenge for states has been figuring out with a non-licensed clinician how they distribute the Medicaid financing. So one of the things that I'm really meaning when I talk about the team-based care is that team-based care might have community health workers or doulas or other kinds of care coordinators and navigators who really can be part of the medical home, and that the medical home financing is sufficient to include those providers.
Great, thank you. And then Melody Neal, Melody, thank you for your question. And I'm going to rephrase it a little bit. She said, how can disparities be addressed through increasing African-American providers? Or maybe are there any policy levers we can pull to increase African-American providers?
Well, they're actually in the American Rescue Plan Act parts I didn't show you today. There is a big boost in the National Health Service Corps spending for training physicians and nurses and others. And I think, again, how can we leverage those opportunities and those slots into bringing in more people of color into workforce training with those kind of, workforce scholarships and loan repayments and all of that. There's a training school out in Arizona that really they've gone all the way back connecting to federally qualified health centers to identify high school age young people to set them on a career pathway to becoming health workers and health professionals. So it requires intentional, but it's possible.
That's exciting. Thank you. I did not know about that. So I'm going to read a comment from Liz Brown, who is our Medicaid medical director, and as a sign of engagement in Delaware. Thank you, Liz, for attending and listening. And I think it's just a comment, but I'll ask you to your thoughts on this. The American Rescue Act option for states to extend Medicaid coverage to full 12-month postpartum allows for states to receive federal matching funds, which was not previously available for coverage beyond 60 days postpartum. This option starts in April 2022 and is authorized for 5 years. CMS has not yet released detailed guidance on requirements and funding. DMMA will follow up when more information is available from CMS. That would be Delaware.
Yes.
MMA. In the meantime, during the public health emergency, no one is losing Medicaid eligibility once they have it, which is great, effectively providing continuous Medicaid coverage for women beyond the current 60-day postpartum period.
Thank you very much, Dr. Brown. All absolutely correct. And I think some of that I intended to say in more detail, and I felt the little pressure of time, but you're absolutely right. And just to reiterate to people that this is intended to pick up when the public health emergency ends, and that right now, no one is losing Medicaid eligibility if they have it, and that it will be continuous through the public health emergency. We hope that public health emergency ends soon, but it's really an important protection. Thank you for reminding us. So the reason that I'm raising this, and clearly, you're focused on this and thinking about it. The reason that I'm raising it in talks I'm giving with states is that for some states, they're going to have to go to the legislature in this session to secure resources or authority in order to go forward with a state plan option in 2022, that it won't work for them to wait until early 2022 to do that. So I am emphasizing that there's an opportunity to plan. There's an opportunity to get authority from legislatures where needed. And not everybody needs that for a state plan amendment. I frankly don't know in Delaware, but Delaware people will know that. So it's more my thinking about make a plan, make a commitment, and then you're ready when the CMS gives you those other guidelines. But thank you for clarifying all that. Very helpful.
Thank you. And then I'm not sure we're going to be able to get to all of the questions, so thank you everybody for your interest. But one of the next questions is, can you highlight, and this is from April Lyons, thank you, April, can you highlight any Medicaid MCO in the country who has extended their model of care for women beyond just prenatal and postpartum care to include the interconception period you speak of?
There was work on this in Delaware, and there was work on this in Georgia. It was done on a pilot basis and it wasn't continued, but I think it's a kind of a proof of concept that they did it. They had a short-term waiver opportunity and they did basically a pilot demonstration. So I think we've done a proof of concept, and I think that MCOs are willing to do these things if asked. And the opportunity perhaps for states to use the health home option for a very high risk group of women is there. So right now, I don't know of an active MCO doing this, but I do think as these postpartum coverage grows, the opportunity for us to build those models is really there. If you look at, I think I have the citation in the slides too, under the interconception, that I did a whole report funded by the Commonwealth Fund about what states were doing, and that would give you those old examples.
Great. And then there is a comment really about home birth and Medicaid paying for home birth. And so I'll just ask for your thoughts on that.
Mm-hmm. I'm not an expert on home birth. I know that there are places where there is an opportunity to have home birth financed by Medicaid. I think those are decisions that are so intricate and specific to states about what types of home births might be financed, what type of providers do the services. So there's a whole fit question with that. I guess just truly from my personal viewpoint, if we could accelerate the role of midwifery in birth center sites, in prenatal care for low risk women and in births for low risk women, and those inside the hospital birth center opportunities, we're a long way from even doing that part of the work. And I know that statement doesn't make me doesn't get me fans in the home birthing option, but I think we've got that whole middle gap to fill.
Wonderful. Well, with that, we're right on time. I want again, thank you for your all of your insight and all of your wisdom, and for coming back to Delaware to speak with us. This is going to be an important part of our strategic plan moving forward. And so thank you once again.
Oh, it's my pleasure. I look forward to engaging throughout the day.
Thank you. Before we move on to the next talk, as promised, I want to announce the winner of the first door prize, which once again is a beautiful Healthy Women, Healthy Baby polo shirt. And the winner is Carrie Bean. So Carrie, thank you for logging in. Thank you for attending the conference. And we will find a way to get you the shirt. So thank you. I'd like Nick to now introduce Representative Melissa Minor-Brown, who is going to introduce our next speaker. So Representative Minor-Brown.
Thank you, Dr. Paul, and good morning, everyone. Thank you for being here. That was amazing information. I was sitting here taking notes, but to move forward now, I have the pleasure of introducing an amazing speaker, someone who does not want a big hoorah, but it's so important that I say all of this because this person is so amazing, and you'll see when you hear from them. But I am introducing Sonny Kelly. He is a world-class performer, a storyteller, a motivator, and a speaker. He holds a PhD in communication and performance studies from UNC Chapel Hill. He's also a graduate of St. Mary's University with a master's in communication studies, and also Stanford University with a bachelor's in international relations. Currently, he's an instructor of communication at Fayetteville Technical Community College. As a professor and a scholar, Sonny's research and work focus on interpersonal communication, performance, critical pedagogy, and public speaking. His research is based upon developing trauma-informed, performance-based interventions to empower underserved youth to counter the school to prison pipeline. So without further ado, I am going to introduce to you Mr. Sonny Kelly.
Thank you so much, Mimi. Thank you, DHMIC family, for having me. I just want to take a moment to just hold some space for all that you all have been going through over the past several years, but especially this year. There's a lot that we have not been able to metabolize and to digest because we're too busy serving and helping. And so I thank you all for being frontline workers. I thank you all for being frontline thinkers. I thank you all for, as you will learn a little bit later, for taking a metaphysical approach to public health and realizing that this is a heart issue. It's a spiritual issue as well as a body issue. So today, my job, my opportunity is to share with you all how I have learned as a communicator and as a teacher and a performer to turn our stories into connective tissue that can help us to process all that we've been going through, but that also can help us to build strong bonds with each other. So today, we're going to talk about how we can reframe and reclaim relationship through our stories. So I hope you all bear with me as I come to you as a griot, a storyteller in the traditional sense. And as I've been trained in the African and African-American traditions of storytelling, I will start off by just giving you a little call and response. Now, I can't see you, I can't necessarily hear you, but in the spirit, if you will just join me in a simple call of Ago and Ame. In Ghana, West Africa, there's a language called Twi, which is one of the most common languages besides English. And in the Twi language, when a storyteller comes into a community of elders, of young people, of hard workers, of vibrant human beings like you all are today, the storyteller knows that it is not his or her or their job to just come and spill information out, but to share stories that will become our stories, that will become a part of our community. So I present to you today a few stories that are my stories now, but I offer them up to you as connective tissue that will become our stories. So in that tradition, the griot, the storyteller, would call out, Ago. Ago means I am knocking. I have come to this village circle. I want to share my stories so they can become our stories and strengthen us together. And so when I call Ago, I am inviting you to hear my stories, but you don't have to hear them. You don't have to listen. As a matter of fact, you can check out right now, go make a sandwich if you like. You'll miss out on a lot, but go ahead. That's what you prefer to do. But if you want to stay and share in these stories, and allow my stories to become our stories and share in this exchange of building relationship and community, I'm going to ask you to respond with Ame. Ame means yes. Yes, I will witness. Yes, I will listen. Yes, I will share and allow your stories to become my stories so they can become our stories. To my Ago, you will respond Ame. Let's try this. Ago! See, some of y'all are being cool. Some of y'all are hanging out like, he can't hear me. I'm good. I'm good. No, I want everybody in the spirit of storytelling, in the spirit of reframing and reclaiming relationship through our stories to join in, even if it's a whisper, even if you don't have voice and you want to just type in Ame, A-M-E, I think is how I spell it, which sounds similar to amor, which is love. There's love in listening. Feel that connection. One more time. Ago! Yes, my family, I thank you. I thank you for welcoming me into the community to share my stories so they can become our stories. I will start with this. It's a poem that I share whenever I'm meeting a group of diverse people who are looking to build community with each other. 6 humans trapped by happenstance in bleak and bitter cold. Each possessed a stick of wood, or so the story is told. The fire dying in need of logs, the first one held his back. For of the faces round the fire, he noticed one was black. The next man looking across the way saw one not from his church and couldn't bring himself to give the fire his stick of birch. Poor man sat in tattered clothes and gave his coat a hitch. Why should his log be put to use to warm the idle rich? The rich man sat back and thought of all the wealth he had in store and how to keep what he had earned from the lazy, shiftless poor. The black man's face bespoke revenge as the fire passed from his sight. See, all he saw in his stick of wood was a chance to spite the white. The next man of this forlorn group gave not except for gain, giving only to those who gave. was how he played the game. Each held his log in death's still hands as proof of human sin. They didn't die from the cold without. They died from the cold within. That is a beautiful poem called The Cold Within, written by a man named James Patrick Kinney, circa 1964. And I present that poem because sadly it is a reminder of where many of us are in our communities today. We've got people suffering and hurting in these silos, separately, not connecting, not sharing, not empathizing. And it's not always by choice. It's just they can't see the fires right there. And that little stick that you have, I know you don't think it's trained enough. I know it's not an expert in your opinion or in some other people's opinions. I know that it may be rough on the edges at times. But that little gift that you have, that expertise, that experience, that heart to help and to do something, it matters. And when you withhold it from the rest of the community, we all suffer. So I like to liken this little stick in this metaphorical story, this allegory, to our stories, our experience, our own personal life experience and wisdom that we bring into a space. And anytime we walk into a room, anytime we walk into a clinic, into an engagement with a client or with medical health professionals or with the public, we have a little something we can put into the fire to share grace, to share love, to share a witness, to share a story. And you would be surprised at how much your story can move hearts, can embrace people, can encourage people. Some people are just waiting for that one person to stand up and say, it happened to me. That's what we call the Me Too movement, right? Me too. Thanks for sharing. I needed somebody to put one little stick in the fire so I could say me too, and I could have healing. I could have solidarity. I could have community and knowing I'm not alone. Sometimes that's all we need to do. Beyond the diagnosis, beyond the statistics, beyond your research, beyond your work. Those things are wonderful to help to reform and reframe form and function of our bodies. But what about our hearts? And I contend that our stories, our little stories, short and sweet, sometimes longer, sometimes they're not our own. Sometimes they belong to me mom, meepaw, peepaw, and grandma, and big mama, and big daddy, and abuelo, abuela, lola, lolo, whatever you call them. But they pass them on to us as gifts, and we can share them. So speaking of passing things on, I want to share with you all a story that I wrote years ago in 2015, when, not unlike today, our nation was going through the throes of some very serious racial tension and serious civilian versus police tension and concerns about the names of people like Freddie Gray and Sandra Bland, Trayvon Martin. Well, today we're still going through many of those same struggles. And if you live in the Minneapolis area, and if you live in areas of Wisconsin, some of the areas where we're seeing even more of the tension happening, I know my prayers and my thoughts are with you and your community, because there's a lot going on for those who know people who are in those areas or whoever operate in those areas. But today I want to talk about how I had to try to process all of this and share it with a 7-year-old. As I say in this piece called The Talk, how do you explain to a 7-year-old his all-encompassing Blackness? Let me clarify. Here's an excerpt from The Talk. I've only just a minute, only 60 seconds in it. Forced upon me, can't refuse it. I didn't seek it. I didn't choose it, but it's up to me to use it. I must suffer if I lose it, give an account if I abuse it. Just a tiny little minute, but eternity is in it. All right, you got everything? Backpack, lunch, glasses. Come on, man. You know the rules. Glasses should be where? In the case of... On my face. I got him, Daddy. All right. Looking good, my man. Hey, and make sure you don't leave any fruits or vegetables in that lunch bag today, all right? Eat it all, you hear me? Don't you bring another piece of broccoli back to my house, you got it? But Daddy, sometimes I run out of time at lunch. I bet you don't ever run out of time to drink chocolate milk or eat pizza, do you? Don't you bring another piece of broccoli back to my house. You got it? Yes, sir. Hey. Who loves you? Daddy and mommy. Who? Daddy and mommy. That's right. And how much do we love you? Mucho, mucho, mucho. You got it. And what's that mean? A lot, a lot, a lot. That's right. A lot, a lot, a lot. Just then I turned on the radio, just in time to hear reports of violence in the streets of West Baltimore, Maryland. There was protests, and there was rioting, and there was looting, and there was a lot of violence. I learned that the cause of all of this was protest over the death of an unarmed Black man named Freddie Gray, just 25 years old, while he was in custody of Baltimore police. He just died. Son, we need to talk. Langston Hughes, let America be America again. Let it be the dream it used to be. Let it be the pioneer on the plain seeking a home where he himself is free. America never was America to me. Good morning, friends. I said, good morning, friends. Type it in the chat. Holler it out. Let me hear you. Good morning, friends. Thank you. Folks, it is about time that we had a talk. In this often confusing, always uncertain, painfully thought-provoking age of the postmodern, the post-colonial, the post-racial, the post-whatever else you want to call it, we need to talk. We're not talking. We're using words. But it's very rare that we ever talk. We tend to debate and defend and rationalize and run away. But today, can we commit to just talking, you and me? Can we talk? No, it's a real question from me to you. Can we talk, family? Thank you. The talk, as it has come to be known, is a resounding epidemic in communities of color in these United States. It is an activated artifact of an age long gone, a new craze based on an old habit. It's the kind of talk that Mamie Till had with her only child, 14-year-old Emmett, back in the summer of 1955. As she nervously packed him up for a trip from his native Chicago to visit her family down in Money, Mississippi. On that bright, sunny August morning, Emmett was warned in the deep, desperate tones of a mother who knew all too well the dire danger that Jim Crow justice posed to the bodies of bright Black boys from Chicago. She called him by his nickname, Bo. Now you listen here, Bo. Please. Just put a handle on those yeses and nos. Say yes, ma'am, and no, sir. Say yes, Mr. So-and-so, and no, Mrs. So-and-so. That talk turned out to be their last. Just a few days later, Emmett Lewis Till would be beaten, murdered, his body tossed into the Tallahatchie River by Roy Bryant and his half-brother, J.W. Milam, two angry white men who merely suspected that Emmett had flirted with a white woman, Roy's wife, Carolyn. Shortly after Roy and J.W. were found not guilty by a jury of their peers, they openly admitted to the murder. Mamie insisted on an open casket funeral. Have you ever sent a loved son on vacation and had him returned to you in a pine box, so horribly battered and waterlogged that someone needs to tell you that this sickening sight is your son, lynched. Let the people see what I've seen. I think everybody needs to know what has happened to Emmett Till. Now I like to think that things have changed since 1955, right? And they have. But I want to take you to 2012, Sunday, February 26th, when a 17-year-old black boy named Trayvon Martin stopped by a community watch patroller, a man named George Zimmerman, a man who merely suspects that Trayvon is a criminal, armed with only a bag of Skittles and a can of Arizona tea that he just purchased from a local convenience store. Trayvon is stopped, shot, and killed that night. The following year, shortly after Mr. Zimmerman was found not guilty of Trayvon's death in a court of law, U.S. Attorney General Eric Holder addressed the NAACP. Trayvon's death last spring caused me to sit down to have a conversation with my own 15-year-old son, like my dad did with me. This was a father-son tradition I hope would not need to be handed down. But as a father who loves his son and who is more knowing in the ways of the world, I had to do this to protect my boy. I am his father, and it is my responsibility not to burden him with the baggage of eras long gone, but to make him aware of the world he must still confront. Let America be the dream the dreamers dreamed. Let it be that great strong land of love where never kings connive nor tyrants scheme, that any man be crushed by one above. It never was America to me. I'm reminded of the words of North Carolina poet Howard L. Kraft in his piece, Grandma's Letter to Peanut During His Freshman Year. I was bragging on you to Mrs. Johnson Sunday. My big rusty butt grandson is a freshman in college. I remember when you was playing with Power Rangers. Now look at you, all grown up and smart, handsome. Still, there's some things I want you to keep in mind. I ain't worried about you studying. You always made A's. And your mama and your daddy don't talk to you about drinking and them fast-tailed gals. So I ain't concerned about that neither. Just remember, that college you go to, it's mostly white. And you're going to have plenty of white friends. But the world y'all share ain't the same. When you get stopped by the police, you put your hands on the wheel and look straight ahead. Don't make no quick movements. You say yes, sir, and no, sir, and don't ask no questions. Just take the ticket and we'll deal with it later. And if the lights ever come on behind you at night, you don't stop until you in a public place. Now, I know you done heard this 100 times, but the time you don't heed it, we'll be headed to Greer's funeral home to make arrangements. And my heart couldn't take that, baby. Oh, let my land be a land where liberty is crowned with no false patriotic wreath, but opportunity is real and life is free. Equality is in the air we breathe. There's never been equality for me, nor freedom in this homeland of the free. The talk has become sort of an undesired discursive heirloom, an habitual hand-me-down from generation to generation, a persistent reminder that on any given day in this great land, the location, disposition, and recognition of any particular black body may place that black body into the crosshairs of imminent deadly force. son, son, he has this beautifully brown chocolate skin that he gets from his mother. These deep, dark brown eyes that hide behind the rounded folds of his cheeks when he smiles, he gets those from me. Dark, tightly curly hair designed by God to grow from his scalp and protect his precious brain from the intense African sun. His name is Sterling. I remember the first day I met him. My Sterling? I remember being in this hospital and there are these lights and these people and this baby who's screaming like somebody's killing him. I remember staring into his cute little face and his little brown eyes squinting at the glare of the hospital lights, and he is wailing. And I look over to his mother, and she is exhausted, like 20-something hours of labor, right? But somehow she is more angelic and alluring to me than ever before. And she gives me the nod, right? So I walk up to my firstborn child here. And y'all, it was like that first scene out of Roots, you know, where Kunta Kinte's father holds him up in the African forest with the moon. I'm dating myself. Okay, we got some millennials here. First scene out of Lion King, okay? Rafiki, Simba, Pride Rock, you with me? Okay, like that first scene, just majestic, right? Only instead of a lush African forest or a sprawling savanna, I'm in this hospital with these people and these lights and this baby who's screaming like somebody's killing him. You are Sterling. He stops crying. Our eyes lock. And in that moment, I was his, and he was mine. Sterling, born on Saturday, December 8th, 2007. Sterling is from the Middle English steor, meaning star, followed by the diminutive suffix ling, meaning little star. Figuratively, it has come to mean pure and thoroughly excellent, as he will always be in my eyes. Sterling is named after one of my best friends from Stanford University, Sterling K. Brown, the award-winning actor. His middle name, Barron, is a combination of his grandfather's names. My father's name was Barry, and my wife's father's name is Ron. So Sterling Barron Kelly. He is the walking, breathing legacy of generations of workers and fighters and survivors. Firefighters, police officers, soldiers, sailors, airmen, and Marines. Preachers and teachers, hustlers and cleaning women, pillars of communities. And in those big brown eyes, y'all, I can see infinite possibilities. But today, when I look into my back seat, all I can see is a black boy. A black boy who will one day become a black man. A black man who will look an awful lot like the pictures I had seen on the news of the now deceased Freddie Gray. Son, we need to talk. And that is my experience with the talk. My first talk with my then 7-year-old son, Sterling Kelly, in 2015. After I had that talk with him, I didn't realize how traumatic it was for me until about a week or two later. I was in downtown Fayetteville, North Carolina, where I live, and I just started thinking it through. You know how trauma will just it's like a specter. It'll just jump up on you when you least expect it, usually when it's inconvenient, like when you're on a public street and you're a grown man and just crying like a rainforest on my face. I mean, literally my face was streaming with tears as I wondered if I'd stolen that child's innocence, if I'd racialized him in a racialized world, as if you can raise a child to be colorblind in a country that is not ever colorblind and never has been, and hopefully one day will be, but it's not yet. I'd wondered if I'd broken him. And I was afraid. And I was a bit ashamed. as oftentimes we are when we are traumatized or victimized. We wonder, what part did I have in that? How did I call that upon myself? And I realized that this talk was a talk that my father received, and his father received, and his father received. And it's been given by men and women and people who truly care about their children for generations in this country, who just want their children to survive. But when they send their children out, they know that that talk is not a panacea. That talk is not a magical, invisible cloak, though we would love it to be, that will protect you from hurt, harm, and danger of those who will misrecognize you. They will misjudge you. My son is truly, truly a jewel, a treasure. He's a salt of the earth kind of guy. But I do know that in this country, for some people, not everyone, for some people, his black skin and his broad shoulders and his strong muscles will speak threat. And they will put a target on his chest or his back or whatever other part of his body that is accessible to people with power and with pistols. And I cannot control it. But what I can do is share with you, my family, my community, my experience, not in a way to call you out, but rather to call you in and ask you to consider the talk that I have that maybe some of you don't have to have with your children. Maybe some of you have had to have it multiple times for different things, for different reasons. Maybe your child is a female or feminine. And we know how in this society, we disparage and destroy and objectify that which is female and feminine on a regular basis. We as a society, maybe you have to teach them or her how to protect themselves, knowing that your words won't be a magical cloak. But I'm grateful that in my sharing of my talk, I've talked to people who are parents of feminine and female people and non-binary people who have helped me to understand how I can better protect and cover, and most importantly, claim them as my community, because now I know your story. Now we can talk with the same lexicon. I may not always understand your perspective. I'm not going to pretend that I can empathize with everything, but I can listen to a story. I can cry with you. I can laugh with you. I can begin to relate. These stories become the connective tissue. Someone has said they needed tissues, connective tissue. I love the connection. See, we're all creating poetry together. As we start to tell our stories and witness, we're involved in this exchange of poetry and creation. And the word poetry comes from the Greek poesia, to create. One of my favorite musicals of all time, Rent, has a great line in it that is, I always say it everywhere I go. It says, the opposite of war isn't peace, it's creation. Creation. How do we create new possibilities for ourselves, for our clients, for our communities? We share these stories that we oftentimes, we think, oh, the old thing, my meemaw told me that, my peepaw told me that. Oh, that's just something that happened to me. It's a thing that happened. That thing that happened to you is a story that's worth telling. It's worth using to connect, to create this tissue that we're talking about. And so as we're telling stories, I like to give people 4 Ds that I want you to consider when you're telling your story. And I hope and pray you will tell your stories. Please do. And as you tell these stories, I want you to consider these 4 Ds. Number 1, remember that your story must have a destination. The great Stephen Covey, the writer of The 7 Habits of Highly Effective People, says you must begin with the end in mind, right? There's no joke without a punchline, right? If I were to say knock, knock, until you say who's there, we can't go anywhere. My son, Langston, my youngest son, Langston once told me a joke. His big brother told him a joke and he wanted to come and share it with me. And he says, Daddy, I have a joke. I said, great. I'm a funny guy. I must have passed it down in the genes. Holla at your boy. Come on, Langston, tell me a joke. You're named after Langston Hughes. There you go. There you go. You're a poet already. So he says, Daddy, here's the joke. I said, all right, what's the joke? Here's the joke. All right, what's the joke? You know, I like to play with him a little bit. He's working on his timing and his flow, right? So I want to make sure that I challenge him and push back a little bit. He said, okay, Daddy, you gonna let me tell the joke? Yeah, I'm gonna let you tell the joke. Let me tell the joke. Okay, tell the joke. So he finally says, Daddy, okay, there were 2 guys in a boat. All right, 2 guys in a boat. Daddy, stop repeating me, okay? Just gonna listen. I do believe in rhythms and patterns, but I'm okay. I'm going to let his rhythm and pattern be set by himself. So 2 guys in a boat. Okay, there are 2 guys in the boat. One guy's name is Pete. Other guy's name is Repeat. All right. Pete gets off the boat. Who's on the boat, Daddy? Daddy, say something. Oh, okay. I can go now. Okay. So tell me again. 2 guys on the boat. Pete and Repeat. Pete gets off the boat. Who's on the boat? Repeat. 2 guys on the boat. 2 guys on the boat. Pete and Repeat. Pete gets off the boat, Daddy. Who's on the boat? Repeat. 2 guys on the boat. And what he didn't realize was that he was supposed to play into me saying repeat, and I was supposed to get annoyed with it and say repeat, and realize that there was a double entendre going on there. But instead, I just played it straight. I was like, repeat, repeat, repeat. And because I didn't get frustrated, he missed the timing. He didn't realize that the punchline is for me to say, What are you doing? Repeat, repeat, repeat. You told, and his final line is supposed to be, you told me to repeat. And I said, oh, you got me, but I wouldn't let him get me. So I resisted the destination. And because he hadn't told this joke much in the past, and he wasn't sure of how to land the punchline, he didn't realize that he needed me in the punchline. He never was able to land it. So we went on like this for a while. So finally, he was the one that got frustrated and said, Daddy, it's repeat. I know, I said repeat. Wait a second. Let me go back and talk to Sterling. He had to go and review the destination because he hadn't practiced it. He didn't know what he really wanted to get to. He wanted to laugh. He wanted the product, but he didn't understand the process. So when we're telling a story, we must understand that we have a destination. What do you want to teach people? What do you want to get out of this story? And what's the process you're going to use? So in the talk, I just want to connect to a community full of people that probably don't know what the talk is. When I say the talk to many of my friends who are white or people who aren't living the African-American experience, many of them say, oh, it's the birds and the bees. They don't know. So part of my destination is to educate people. Part of my destination is to draw them into the pain that I experienced, not to blame, not to put guilt on them, but to say, hey, I'm a family member of yours, right? I'm a community member of yours. I'm going through this pain. Will you hold this space with me? Will you witness it with me? Will you help me? Don't deny it. Don't debate, don't defend, don't rationalize, don't run away. Just sit with me in this pain and just let's acknowledge that it exists, first of all, and it's not in my imagination. And then let's see if we can work on ways together to end it, to mobilize our privilege. I love privilege, y'all. Privilege is a beautiful thing. No one in this room should feel guilty for your privilege. I have male privilege. And guess what I can do? I can use it to protect, to defend, to stand up for, stand up with, to share voice, to share space. Use privilege. It's a tool. No one should feel guilty for having privilege. Now, if you misuse it or you don't use it for a part of the solution or for good, then yeah, you should check yourself before you wreck yourself. That's a little ice cube for you. I'm from California. Got to give you all a shout out. So destination, know where you want to go. Know how you want to use your privilege. Know how you want to use your story. How do you want to mobilize it? What do you want to get out of and get with this audience? And when you begin with that end in mind, it will guide the stories that you bring up, the poetry that comes up, the words that you use, the connection that you have with your audience. Know what you want to get out of this conversation. What do you want to learn? What do you want to teach? How do you want to persuade your audience? Number 2, the details. I always like to say the dynamite is in the details, right? So I like to talk about the meanings of names. Langston, his name means long stone. And he's partially named after Langston Hughes, but when Langston was born, or when he was in utero, my wife had an indication from the doctor. We received an indication that he had a high risk of being born with Down syndrome. We knew we were going to have him, but we were concerned about that challenge. We hadn't raised a child with special needs, and we were praying about it. And my wife had a revelation. She woke up one night and she told me his name is Langston. And the connection she made was with our faith. Langston means long stone in the Old English. And we believe that Christ is the stone, the cornerstone of our faith. And we believe it. And we have faith that he will get us through no matter what the difficult situation is, no matter what cross we have to bear, right? As he bore this cross. So Langston has multiple meanings. And the details of his meanings I share with you all to share with you how I treat him, how I see him, how I love on him is informed by all these layers. How we deal with each other, it's informed by layers. And we do each other a disservice if we don't consider the details that speak to our scripts, the scripts by which we interact with each other and respond, that speak to our sense of self-concept, identity, etc. And anybody can tell you, a great book, especially a great novel, always begins with these lovely details, right? The dew dripping off the waxy leaf onto the plain, right? It draws you in. You know that when a human gives you certain details, like the meanings of a name, like the description of the terrain, like the colors and the smells that are in the room, it means you should draw in because there's something there that's deeper. The details are kind of the curtains around a core issue that you were going to get to. The details, they caress and they provide a curtain around the destination of where we want to go, right? So details are important. Don't blow them off. So whether it's how someone's hair looked that day or how you felt or what the smells were, etc., draw us into those details as you share these stories. Next, my specialty, drama. Bring in your pathos. In the Greek, pathos is your emotion, your heart, right? So often in this world, we are told to be careful with our emotions. If you're a female or feminine person, especially if you're a female or feminine person of color, don't be the angry, whatever, fill in the blank, right? Don't become a bee. I'm going to say a bee because I hate that word. It's for a female dog. You know, all of a sudden, if you're angry, you're a bee. If a man's angry or a masculine person is angry, then they're just assertive. That's a good leader, right? We're not allowed to show our emotions. Then on the masculine and male side of things, if we're to cry, like I cry when I share the talk, those are my tears. I lament. I mourn Freddie Gray. I mourn Emmett Till. I honor and mourn and lament what Mamie Till had to go through. I feel that in my heart. I allow myself to feel that in a society where, as a male and as a person who presents as masculine, it's generally not acceptable for me to cry in public or to say, I'm not sure of how to give this talk to my son. I didn't have all the answers. I'm afraid I may have gotten it wrong. How great would it be if we were to say, you know what? It's okay if you got a misdiagnosis. It's okay if you miscalled it, if you didn't know the full story, because guess what? Ignorance is an opportunity to learn. Ignorance is not a marker of malevolence. It is an opportunity to learn. Now, when you're ignorant and you're willfully ignorant, then that's problematic. We need to correct that. We need to correct bad behavior. We need to educate ignorance. And so when it comes to sharing our emotions about things, if you're frustrated, if you're upset, if you're scared, if you just don't know, you got to find a way as a storyteller to express that. Let yourself cry. Let yourself laugh. Let yourself feel hopeful, because when you do, you'll give permission to others to do the same. Little Marianne Williamson for you, Our Deepest Fear. If you've heard that poem, please memorize that, learn it. Our deepest fear is not that we are inadequate. Our deepest fear is that we are powerful beyond measure. It is our light, not our darkness, that most frightens us. We ask ourselves, who am I to be brilliant, gorgeous, talented, and fabulous? Who are you not to be? You are a child of God. Your playing small does not serve the world. There's nothing enlightened about you shrinking so that other people will not feel insecure around you. You were born to make manifest the glory of God that is within you. It's within all of us, not just some of us, but everyone. And as we let our own light shine, we unconsciously give others permission to do the same. As we are liberated from our own fears, our presence automatically liberates others. As you liberate your heart and you share the true heart of the story, you let the story breathe, as I like to say. You'll find that you're not being fake, you're not being dramatic, you're just letting yourself feel and process and metabolize whatever trauma or whatever joy you've experienced, and then it gives the rest of us permission to do the same. And we can spark and connect it to our stories as well. It's a beautiful connective practice. So let the drama flow, don't hold back on it. Finally, dialogue. As you all saw earlier, and I thank you so much for your participation, we did ago, ame. I said good morning, and some people said good morning back to me right there with your coffee and in your bathrobe, or some of y'all, your business up top, sleepy time down low. I know how you're getting down. Just stay seated. We're good. Just keep that angle right? But we engage in this dialogic process, which for me, I've been taught in the African and African-American storytelling tradition to call and respond. And it's been a part of how we as African Americans really have processed some of the trauma we've experienced over the last several centuries. There's a book by Resmaa Menakem. If you have not read it, I would suggest everyone pick up a copy. It's called My Grandmother's Hands. And he talks about how he would massage his grandmother's hands when he was a young man, and even a boy perhaps. And his grandmother had these calloused hands, and she was a hardworking woman who'd been through so much: Jim Crow, segregation, discrimination, poverty, imposed poverty, right? Cyclical poverty, cyclical racism, all these things. I mean, at the apex of these things, right? And she still had hope, and she still had joy, and she still had a tenderness about her to nurture her children. And he remembered just massaging those rough hands, and he got the spark from that experience to start talking about trauma, not in a way that that victimizes anyone, or not in the way that just keeps us in that place of lamentation, or locks us into a place of sorrow, but says, you know what, it's there. Let's use it. Let's move through it. Let's, as he says, metabolize it. And he uses this term. He said, let's move toward somatic abolition. I love it. When you start getting at this PhD level and you all start studying, you get to make up new concepts. Somatic abolition, somatic, the body, abolition, abolishing slavery and coming to freedom. And so if you haven't read Resmaa Menakem's My Grandmother's Hands, I definitely suggest you do that. In my show, The Talk, I play my grandmother, Ma, and she would always say, get your lesson. Now, Ma had a 7th grade education, but she believed firmly in the power of education. So if any one of us children, our grandchildren, great-grandchildren, et cetera, down the line, I think she lived to meet great-great-grandchildren, and she saw us studying. And if we looked up for just a moment to, I don't know, breathe or think, Ma would square up on you like she was willing to fight you, right? Like a drill sergeant, get your lesson. And then I mentioned Ma was deaf, so no concept of volume control here, right? But the moment you went back to reading or doing your homework, she would just sit back, quiet as a mouse, and she would just watch you. She had invested so much hope in us that she was able to find strength, even though she'd experienced so much trauma, find strength in the hope of new beginnings for her children, her grandchildren, her great-grandchildren. And so as we talk about dialogue, it's so important that we go back and forth and share this energy and share these conversations and find out where we have connection, right? Which leads me to this important element that I want us to apply when we're listening to a story or we're witnessing a story, which is a gift. It's a gift for you to just sit and listen. But we're listening to a story, we're giving a gift to someone, and they're sharing a story we don't agree with. They're sharing a story that is emblematic of some of the ignorance and some of the ultra-conservatism or reactionaryism that we see, where people are saying, I don't want to change. I don't think race is a problem. I don't think gender is a problem. I think everybody's fine. You're so focused on these outcomes. What about the fact that, and they ... right? Whatever apologetics people have for justifying the fact that there is inequity in society. And it's just really about, the individual and accountability. Well, we know there's a balance, right? I don't want to say that accountability is not an issue, right? We need to all make better choices, everyone in this life. But some of us are confined to certain trajectories based upon cycles and centuries of cycles of poverty, imposed legal poverty, right? And violence, etc. So we need to address that and process that. Well, in doing that, we, of course, need to be dialogic and have a back and forth and a conversation so we can figure out where our different blind spots are, where our different areas of ignorance are, so that we can inform that ignorance with education. And when we hear these stories that we don't agree with, or these stories that, come from a perspective we're not entirely comfortable with, it's important that we don't throw up in our mouths. Well, if you do throw up in your mouth, don't make it obvious. Just, okay, don't, oh my goodness, no, don't do that, right? We've got to listen because there's potential to connect here. And there's a guy named David Campt, C-A-M-P-T. He's a PhD in psychology. He wrote a book called the White Allies Toolkit Workbook. And I got this book as I was writing my dissertation because I was dealing with this concept of the talk and Black youth and connecting Black youth to community and reframing and reclaiming their sense of identity in a welcoming, loving, diverse community. And so I wanted to make sure that white people and people who are not Black were included in that conversation. And David Campt gives us this beautiful acronym, RACE. Whenever you're hearing a story that you disagree with or that just triggers you in some way, it makes you tense. As Resmaa Menakem said, listen to your body. If you feel yourself tensing up, don't deny it, don't run away. If you can tolerate it, try to just acknowledge it, breathe through it. Now, if you get to a point where you're spinning out of control and you are starting to really feel a deep sense of anger, fury even, and your fight, flight, or freeze mechanism kicks in, well, please don't allow yourself to stay in that triggered, unhealthy, mentally unhealthy situation. You might need to pull yourself out. But if you can endure, if you can go through what I call deliberate discomfort, because deliberate discomfort is generative. That is to stay in the space, right? Whenever you've been injured, if you have to put ice on it, oh, it's so uncomfortable. Or you have to put heat on it, but really hot heat. Oh, it's so uncomfortable at first. But when you stay in that space, there can be healing. There's potential, there's possibility, right? So David Campt says, apply RACE, R-A-C-E. When you're hearing a story you don't agree with or you can't relate to, first reflect. Just kind of try to find areas where you can empathize and reflect upon their perspective. Realize that their perspective is not your perspective. And as my grandmother once said, people do better when they know better. Maybe these folks just don't know your perspective. They don't know your experience. So just reflect on what they've gone through and the fact that you do have some things that you may have in common. Then ask. There are things that you don't know. It's okay to be ignorant. Ignorance is an opportunity, right? So I want to challenge you all to ask questions. So what did you mean by that? When people call you a redneck, you said you feel like the same way I might feel when people call me the N-word? Instead of saying, no, they're not the same thing, say, well, tell me about that. And I've had a chance to talk to people who say, when I'm called a redneck, it means I'm not a human. And I'm like, when I'm called the N-word, it means I'm not a human. It's not exactly the same thing, but I can see by asking that there is a real connection here, which leads us to see, connect. We've got to find connections. What do we have in common? Not comparison, not oppression Olympics. I was poorer than you. I was so poor, we couldn't pay attention, right? No, I'm not talking about playing the dozens, as my dad would say. I'm talking about just finding connection. Okay, I can see. I can't totally relate, but I can see how you felt that way. I totally disagree with your choice, but I see how you made that choice. I'm making a connection. I can see the rationality of it. Or in some cases, I see the irrationality of it because the fight, flight, or flee mechanism is not rational. It comes from trauma that we've experienced we have not yet healthily metabolized. My argument is that through our stories, we can begin to metabolize it. But sometimes you can say, oh, I see. You're doing something that makes no sense. I totally disagree with, but I do see that you had trauma. Thanks for sharing with me. I was able to reflect, to ask questions and clarify. Then I could connect because I've had trauma too. And I've done some things that didn't make sense or were self-defeating or were hurtful or even hateful. And I didn't even know why I did it because they were a knee-jerk reflexive response to the trauma that I had not yet metabolized. And then finally, E, R-A-C-E, reflect, ask, find connections, and then E, expand. Now I hear what you're saying. I thank you for sharing your perspective with me. And if I'm honest, I did throw open my mouth a little bit at the beginning, but I was able to clarify. And I see now what you meant. Now, what if we thought about it this way? What if we both had the talk with our kids about race? Maybe we did it together. Or maybe we did it in a way that we didn't have your kids feeling guilty. We didn't have my kids feeling inferior, but we said, you know what? You are great kids. And we live in an imperfect society. We want to challenge you to change our society in a way that you don't have to have the same talk with your kids. But race is real. And racism is like a toxin. It's like COVID-19. Anybody can get it. Anybody can act it out. Sometimes I have, if I'm honest. But guess what? There's a cure. It's conversation. It's connection. It's hard to hate people when you know their stories. So I want to take a moment here just to share with you all a quick statement that a friend of mine named True Pettigrew taught me that I hope if you haven't learned already that you write this down, okay? Because this has changed the way that I teach, the way that I minister to people in a spiritual aspect, the way that I deal with my students when I'm counseling them, the way I deal with my colleagues, even my family. True Pettigrew, he is the founder of True Access. He does a lot of training. I think right now, as a matter of fact, I think he's working with the Timberwolves. He's kind of the team chaplain with them there. But he started a program here in Cary, North Carolina. And he and Tony Gwynn, who was at that time the police chief of Cary, North Carolina, they got together. And so True Pettigrew, just so you know, is an African-American man, a father of a boy like me. And Tony Gwynn is a white man. He's also a father, I think, of a boy and a girl. And Tony Gwynn was the police chief there. And so they got together and said, we've got to find a connection between police bodies and Black bodies and the community bodies, the polis, as it were. And so they started a program called, every first Saturday of the month, I think they still do it now in Cary, and it's called Barbershop Rap Sessions, where people just come and let their hair down, literally, and just hang out in the barbershop and talk. And they built trust and community and shared stories. And it was a beautiful, amazing experience that goes on today, even though both of them have moved on to other projects. So your stories have lasting power. Our stories may even be forgotten, but people will still remember the essence of them, right? They'll still remember the destination. They may forget some of the details, the drama, but they'll remember the dialogue. They'll remember that they were connected, and they will definitely remember the destination of those stories. So I love the fact that we can tell stories, and when we walk away, they're no longer ours individually, but they're ours communally. And they go on to live and to educate and to empower people even when we leave, right? The gift that keeps on giving. And so True told me this. He said, Sonny, when you're going to tell stories to people or train them or connect with them and try to persuade them, you've got to remember three things. Number one, you've got to meet them where they are, not where you want to be. We talk a lot about shoulda, coulda. I shouldn't have to have that talk. My people have been oppressed. I shouldn't have to lead the way. I shouldn't. And that's all true. But I don't live in the hypothetical. I live in the real. And what is what is. And so I'm going to apply the best gift that I have to address what is my stories, my intelligence, my connection with human beings, my communication, whatever your gift is, you got to deal with what is. Now aspire for what should be, but we're living in what is. So meet people where they are, not where you want them to be. And here's a tough one. Love them for whom they are, not who you want them to be. Listen to their story. Love them by witnessing. Love them by sharing your own stories and your own vulnerability. Love them right where they are and just hope that they'll listen as you're listening to them. Then and only then can you do number three, lead them where they need to go. No one wants to follow you if they don't know that you care about them. No one cares how much you know till they know how much you care. How do they know if you care? You share your stories, you listen to their stories, you humanize them, and you hope that they'll humanize you, knowing that they might not. This is a courageous thing I'm calling for. I'm not calling for safe spaces in your clinics, in your community centers, in your homes, in your spaces. I'm not calling for safe spaces. I think safety is important. But I think courageous spaces is that next level. Courageous spaces say, I'm going to stand up. I don't care how young I am, how Black I am, how white I am, how different I am. I'm going to stand up and share my story and hope that you'll listen. And if you don't, it's going to hurt me. But it's worth the risk. I want to create courageous spaces where we can be deliberately discomforted. We can tell our stories with those 4 Ds. We can share and listen and witness using the race, reflecting, asking, connecting, and expanding so we can create new stories and new possibilities. So I know this sounds impossible to some of you all. I know some of y'all are looking at me and like, what is he talking about? And how is this going to happen? So I'm going to share with you one inspirational poem written over 100 years ago by a guy named Edgar Albert Guest. It's called The Thing That Couldn't Be Done. And I'll leave you with that motivational, inspirational, poetic memory, and then we'll go into some Q&A. Somebody said that it couldn't be done, but he with a chuckle replied, well, maybe it couldn't, but he would be one who wouldn't say till he tried. So with a lift of his chin and a bit of a grin, and if he worried, he did it. He started to sing as he tackled the thing that couldn't be done, and he did it. Somebody scoffed, you can never do that, or at least no one ever had done it. So she took off her hat, and she took off her coat, and the next thing you know, she'd begun it. With the lift of her chin and a bit of a grin, refusing to doubt it or quit it, she started to sing as she tackled the thing that couldn't be done, and she did it. There are thousands who will tell you it cannot be done. There are thousands who will prophesy failure. There are thousands who will point out to you one by one the dangers that wait to assail you. But with the lift of your chin and a bit of your grin, just take off your hat and go to it. Start in to sing as you tackle the thing that couldn't be done, and you do it. So I commission you, I challenge you, I call you, I beg of you, please share your stories. Please witness the stories of others that we may reframe and reclaim community together. This has been a message from Dr. Sonny Kelly, and I do approve this message. I'm sorry, y'all. I'm a clown. I always got to put it in. Let's talk. I know we have a short amount of time, but Mimi, love you and appreciate you. Thank you all so much.
Wow. What a great way to end, actually, because I was like an emotional roller coaster throughout your entire speaking moment. I went from laughing to getting super emotional, especially with some of the words that you spoke that were so relatable to me just as a Black woman and a Black mom, Black mom or a mother of a Black son.
Thank you.
My son was actually watching CNN this morning, and I thought but he wanted to watch it, and he's 7. So I had to do a lot of explaining, which I find myself doing all the time. So thank you for that. And also your empowering words. You brought up Marianne Williamson's poem, Our Deepest Fear. That is my favorite poem.
Yes.
My father gave me a copy of that poem years ago and told me to post it on my mirror and read it every morning. And it was the perfect time for me to have that poem. And I have passed that down to my children, and I want them to pass it down to their children because it's so important to know and understand that poem. So thank you so much for that. I have a question for you. Mm-hmm. I know that you provide training on inclusivity. And with the current Black maternal mortality epidemic that we are suffering from right now in our country, we hear that, and we know that there needs to be some type of training, implicit bias training, inclusivity training. Do you have any advice on how to approach that so that there will be a training that is actually effective, not like a yearly check off these questions, yes or no, training where people really aren't absorbing it?
Yeah, I think this is aspirational, what I'm about to say, because I know some, especially physicians who are tend to be scientific, right? They're not into trying new, my DOs maybe, my DOs, my homeopathic folks, definitely my doulas. But we've got to realize that the way that we enact, whether it's medical or if it's in policing, the way that we enact violence, denying people the meds they need, not engaging with them and asking the right questions, it is knee-jerk. It is not always rational. Many times a doctor will misdiagnose or will think that a Black woman, for example, has a higher pain tolerance or doesn't need to be checked on when she does, because there's something that's subconscious in them that, and I'm going to be very careful when I say this. When you've treated people like cattle for hundreds of years, not you, but our ancestors, right? And I say, my grandmother has blue eyes. So I am a Confederate monument right here. I got Confederates and I got captives in me, right? When we've been in a society where we're able to treat people like cattle, and we call in rather a veterinarian instead of a human doctor, right? For them, we have some of these remnants and these preconceived notions. It's not your fault. It's epigenetic. It's also been a part of the way we treat Black bodies. When you see a man like George Floyd tied up like a calf at a rodeo. I'm from Texas. I've spent some time in Texas. You tie up a calf like that and lean on them like that. And we're all appalled by it. But if we're honest, we're used to it. We see it. It happens. That's what happens to Black people. And if you've noticed, we don't say this consciously, but I'm just going to say what I've observed. George Floyd has a wide nose and thick lips and darker skin. I mean, he's not quite European, and European to us has meant more human. It just has. It's something that's been, nobody here started it, but it's in there. So we've got to acknowledge it. We've got to loose it from our bodies. So what I would suggest is that instead of doing implicit bias training, which people do on an annual basis, they check the box and few things really change. We get together and we allow the community to become experts and share stories and start to move through things. I'm a big fan of Augusto Boal's work. Also, there's a program called I'm trying to remember the name of the program. It'll come to me before we finish. But it is a program where people come together in mixed communities and they do something called the race talk or the race dance, where we start to move through how we feel racially and even in terms of other differences in our space. Start to do a little theater, little movement exercises. It seems silly, but what it does is it allows your body to kind of release some of those preconceived notions that are not your fault. They didn't come from you, but they are in there, and to acknowledge them and deal with them and get close to somebody who's darker skinned or someone who's lighter skinned, someone who eats differently from you, who lives, loves, or I would say who lives, loves, or looks differently from you. Get closer to them and you'll see, oh, they're human. They have a heartbeat as well. And so as we do that and we share stories, we start to humanize. It's the heart issue. It's not a rational thing. I can train you all day in inclusivity and what it is, and we can define it. But to live it out, you got to get close to me. We got to learn how to, and I hate social distancing. We've got to learn how to get close, like to hug each other, to smell each other, to deal with each other, and then to stop and listen and tell each other stories. Now, I'm well trained. I can train you all day long, and I hope that you'll remember my stories. I mean, it is the gift that keeps on giving. But I would love to have a room full of people that you serve and that we all are supposed to serve together, share their expert experience from their own perspectives without their PhDs and MDs and DOs and MAs and NPs and all that kind of stuff. Just, hey, this is my experience. Because sometimes you don't know because you just never were told, right? And so I qualify this. I'm a person who has been well educated. I've got a nice smile, I've been told. My nose is kind of more narrow. I'm a lighter skinned guy. I'm slim. I'm a heterosexual cis male. There's a lot of things, a lot of boxes that I check that let people's guards down in this room and space right now. If I were Stacey Abrams, darker skin, heavyset woman with natural hair, people get real nervous all of a sudden. They don't know why. It's because we've been trained to repel, to be what's the word? To release ourselves of the tension that we feel when something is different from us or someone is different from us. That's actually an interesting play on words. We can call them something when they're different. That's a different tribe, right? So I think it's important that we get in spaces with groups. I think we need to do more group training, storytelling and story sharing, and movement, which brings in performance, and some Augusto Boal's work with the Theater of the Oppressed, where we give people some agency as well, and allow them to play out the scenes and change the scenes, and stop telling white people to stop talking. We've got to stop doing that because we should all be talking. So we say, well, white people, you haven't been through what we've been through. You don't get to talk. Okay, so now he or she is silent, and they sit back silently and nothing happens. And you say, silence is violence. So now he or she tries to say something awkwardly, and they're on eggshells, and they don't know what to do, and they're always going to be wrong, especially if he's a cis, hetero, white male who might be conservative. Are we going to cut him out? No, he's part of our community. So we've got to share our stories and stop trying to make these hierarchies and reproducing hierarchies. Sorry, soapbox stepping down. Mimi, Luther?
Wow. Well, I hope that we can have you back once we don't have to socially distance, and we can have you in that room to begin having those conversations. Okay, I'm going to look over into the question box, and let's see. Dr. Paul actually has a question.
Well, we have a little time, and you kind of answered it, but Sonny, that was so incredible, and I think I want to be the Sonny Kelly of neonatology if it's possible. But
wow, Dr. Paul, I'm honored.
I don't think that can happen, but due to my limits, we have the same hair, same barber, stuff there. But there's so many lessons there to learn for clinicians at the bedside, listening to stories, telling stories. I mean, you answered it, but any specific advice? How does this translate into patient care? The stories we tell and listen to every day in the hospital.
I disagree with the argument that you can't teach an old dog new tricks. I think you certainly can. I think part of the reason why most physicians got into this business is because you love to see people healing and happy and healthy. It's just something in you, right? And so if you realize that stories and storytelling and spending time is a healing element, like there's a reason why we call bedside manner like a whole field of study, right? A skill set. And you don't have to be the most engaging and dynamic person. You just really sometimes have to listen, ask the right questions, breathe, and let the expert knowledge come from the patient. So I want to challenge physicians and all of us who are in the medical field, who are tending to patients, to force yourself to see every engagement with a patient as a destination and not a distraction. I know you're busy. I know you're doing rounds. You're going to be late. You're going to miss something. You're always going to drop a ball. But don't ever let the people be the ones that you drop. If you miss a task, you get late on a test or a report, okay, that's going to happen. But if someone calls you in and they want to talk to you, now you can't stay there all day, but just keep telling yourself this is a destination. This is not a distraction. It's a destination. Now, I'm going to be honest and say, hey, I've only got 10 minutes, Mrs. Jones, but I want to spend this 10 minutes with you. And sit in that 10 minutes. Give yourself that limit. You've let her know you got 10 minutes, but sit in that 10 minutes and receive, and only give when she asks you or if she needs you to give. But you got to designate those times with your children, with your 7-year-old Mimi, for example, or with our children. The same way we have to do that with our children, we need to do it with our patients, not because we're talking down to them, but because they need time. They need space. And with our colleagues, when we've reached capacity and we've just had it up to here with the race talk or with the diversity talk or with just being seen as invisible or with the microaggressions, we got to tap out and say, can I get 10 minutes just to talk to you and share you what just happened to me right now? Not as gossip, but I need to process it. I need you to help me to metabolize it, if you will. Now we have language, right? Let's metabolize what just happened. So I want physicians to see their patients as destinations. Not just the diagnosis, not just the application of the medicine, but the listening, the spending time, even if it's just silence and just holding their hand. What if you did this with every patient that you have that does not have words, that is not able to communicate with you? Maybe they're in a coma. You just designate 5 minutes a day where you're going to just go and hold their hand or spend time. I know we're socially distanced now, but spend time giving energy to them, whether you're a spiritual person and you pray, or you're just a person who just wants to just witness them in that space. I just believe we're going to talk about metaphysical public health later. I believe there's a metaphysical power in sharing space and giving people space to breathe, to share if they want to, or if nothing else, just to be with them as a destination. Part of your practice. Dose it. PRN.
All right. Well, I thank you so much. That was such an incredible presentation. And again, we all learned so much from you. And so thank you for imparting your words and your stories on the state of Delaware.
Paul, we do have a question in the chat, if you don't mind. I asked it really quickly.
Sure. We want to stay on time.
I'll be sure.
Okay. Just one question. This is from Noel Duckworth. They said, first, thank you for this gift. How do we integrate storytelling, not just into programming, but in high-level meetings and plannings? So professional standards are heavily defined by white supremacy culture. We need storytelling to dismantle and create more inclusive, affirming spaces.
Thank you. Okay, Noel, I'm going to be really quick with this. There are 2 practices that I use in my classrooms and whenever I'm having group settings that are really simple. I want you to note this. You've got to create simple, repeatable, consistent rhythms. When you do that, we all can flow with it, right? It's like jazz, right? It's like all of us come from tribal or clan kind of origins, and there was always a percussive instrument to remind us of the season or what we're going to do. When I say all of us, I mean every one of us, right? Whether you're coming from Scotland, Ireland, or Africa, right? And so we've got to create these rhythms. So these are 2 rhythms that I do. When I start a session or a meeting, a business meeting, we go around the room and we say our name and we say and show how we're feeling today. So I might say, I'm Sonny, and today I'm feeling really jazzed. And everybody else would say, I hear you. And at first, they're going to think that it's kind of kooky and kind of silly. But after a while, you get used to it and you start to embody each other's experiences. We're getting used to that somatic abolition. So people might do it small. They might not have the capability to use their hands. They may not have hands. That's okay. It's the intention. So we all go, I hear you. And we kind of laugh at ourselves at first, but we're starting to lower our walls and we're starting to listen to each other better, right? With our bodies and with our eyes and ears, right? And so we go around the circle and we give people space just to share why they're feeling that way. I gave this presentation today for a DHMIC. I met some of the most amazing human beings. And I was so glad I was able to be a little wind beneath their wings. So it just makes me feel like this. And so now people get to know a little bit more of me. I get to share a story. Today, I'm feeling kind of frustrated. I was asked by 3 doctors why my hair was natural, and it is natural. That's why it's natural. Right? But they didn't say, why is it natural? They said, why are you trying to look so different? What does that mean? I'm feeling this right now. And so now that we're doing the I hear you, it's a rhythm and it's a pattern. It's not necessarily a training or an official complaint. It is us just having a conversation in community where we're processing each other's experiences. The last thing that we do besides I hear you is to take a moment really just share with each other how we felt at the end of the meeting. So I always say at the end of the meeting, questions, comments, concerns. This is fair game. We're not going to address it right now because we may not be ready to address it. But was there anything that happened in this meeting or in this week that you'd like to address later, but we maybe need to process it a little bit more, but you just want to put it on the table because this is community and we're going to witness that? Yeah, there were several microaggressions that happened today. I want to just address them when we can and whatever. Or yeah, you know what? I had a great day today. I think we've really done well with each other. And I want to just, can we give ourselves a round of applause? Whatever it is, but just a final thought. We're not going to address it right now, but we are going to name it and we're going to just kind of see how we can process it through the rest of the week until our next meeting. Right.
Great. Thanks so much, Sonny, once again. Greatly appreciated and greatly entertaining and educational. So thank you.
Oh,
Yeah.
thank you.
We are going to take a virtual break. We are going to resume exactly at 10:55 for the world debut of our video on Black maternal health awareness. And just a spoiler alert, there's a lot about listening and stories in the video as a follow-up. So please take the time, visit the innovation stations during the break. You can find them on the left-hand side. And then one last thing before we break, the winner of the next Healthy Women, Healthy Baby shirt is Rubia McBride. So Rubia, congratulations. You'll join our styling team with a new shirt. And we'll see everybody back promptly at 10:55. Thank you.
Hi, everybody. Welcome back. Welcome back. Welcome back. My name is Tiffany Chalk. I'm a community health advocate, and I'm the lead of the DHMIC Well Women and Black Maternal Health Work Group. Today, we are so excited to present to you the first in our series of video presentations, Her Story. As Dr. Kelly just remarkably shared with us the importance and the power of stories and storytellings, this video presentation is right on time. I myself became a part of the work of the DHMIC by telling my own story 14 years ago at the first annual summit. Because sometimes I want to say this, sometimes we can listen, but do we hear? Because as we listen and truly listen to someone else's story, we can broaden our scope of knowledge and understanding. So I leave you with that, and I ask you to turn on your listening ears and listen to the wonderful stories of the women in our state about their experiences with Black maternal health.
The first time I heard that Black women were 3 times more likely to die because of maternal health issues was scary. I never thought that there was that issue before. And now I was in that situation. It made me feel like, what if something is wrong with me? And if I tell my physician or I tell the doctor that's seeing me or the nurse that's seeing me that they're going to help me and they won't help me, what am I going to do?
So as a Black woman, it is truly terrifying that despite having my medical degree, that implicit biases, racism can affect me during my interactions with medical providers.
I didn't feel heard. I didn't feel like I was respected. I just really felt like she looked at me as I'm just a young Black girl in here pregnant. And it's like, they judge that whenever you're in there by yourself. But it's like, I actually had my fiance with me. Sometimes it doesn't matter.
Unfortunately, implicit biases don't just affect thoughts, but they affect behaviors. And patients are aware of those behaviors and those thoughts when they're interacting with providers. And those type of interactions can discourage patients from seeking care.
I try to give everybody the benefit of the doubt. She didn't realize how it was coming off to me and how I was very upset leaving my doctor's appointments every time I went. It was to the point I would call my mom crying, like, I have to get out of here, but then it wasn't no other practices for me to go to.
Unfortunately, there are not enough African American providers or providers from underrepresented backgrounds in medicine. African American physicians comprise almost 5% of the U.S. workforce, but they comprise 13% of the general population.
I believe women should have access to doulas because it gives them an opportunity in cases where they don't understand something, that they can ask those questions.
In the short term, we need better strategies to provide comprehensive care to our mothers. So other initiatives such as doulas have been effective strategies to assist patients in advocating for themselves, as well as providing them with the skills to interact with the health system.
So we've already started having the conversations in reference to postpartum Medicaid. Medicaid needs to extend longer than the 90 days that it extends now. It needs to extend at least to a year. I don't even know if that's long enough, but for now, a year, because we have Black and brown babies that aren't even living beyond 1 year. And those numbers are even higher than maternal health deaths. So that's a problem.
I'm trying to get the news out there that we need to be more aware of what's going on with us as our bodies and also what's going on with our kids.
Learning how to be mindful and controlling my thoughts. I think that's important for me if I do want to become a mom one day, because I also want to raise mentally healthy kids.
We have had a Black to white infant mortality disparity ratio of about 2.7 to 1. So that babies born to Black mothers are 2.7 times more likely compared to babies born to white mothers to die before their first birthday.
I wonder if the doctors would have treated me differently if I had not been a Black woman in that hospital. I also wonder if they would have treated me different if I had not been a fat Black woman in that hospital.
When we take a step back and look at a higher level about what causes premature birth or any health outcomes, probably about 80% of those factors are outside of the walls of the hospital. And it's really those upstream factors, social factors, community level factors that contribute to maternal health, that contribute to infant health.
I think it's really important that healthcare systems are blunt about it. You know, they need to speak up. They need to say, listen, these biases that you have, racism, making patients feel uncomfortable, it's not welcome here. So they need to start there. But also, I think that patients need to have access to advocates. But there also needs to be something in that facility letting patients know that if you don't feel comfortable, if you feel like your questions weren't answered, then this is who you need to talk to. Let us know.
I mean, I feel like the major solution is knowledge. That's it. I mean, knowledge is key. Like, if no one knows what's going on, if they don't have the knowledge, then how are they supposed to know to take care of themselves, or how are they supposed to know to take care of their child? Different things that could happen. It's all about knowledge, and people have to be willing to want to learn too.
Just be mindful of your health. Just be conscious of what you're eating, what you put into your body, exercise. Start reaching out to get medical care, whether it's primary care or just seeing a gynecologist.
It's the historical factors that have really shaped our community in an adverse way. Those factors that have really had downstream effects on whole populations and whole neighborhoods. But we really have to think bigger. We really have to speak louder, and we have to listen to other voices as well to make those changes.
Your health matters now, and it's time to solve the maternal health crisis.
I hope you enjoyed the first part in our video presentation, her story, Black maternal health in our state of Delaware. So now I do have the pleasure of introducing our next keynote speaker, Dr. Karen A. Scott, a reproductive justice, informed sexual, reproductive, perinatal, epidemiologist, educator, and obstetrician hospitalist with more than 20 years of experience in supporting individuals across the sexual and reproductive life course in high need, low resource communities across different practice types and locations throughout the Midwest, Northern, and Central California. Dr. Scott research focuses on the analysis of structural, institutional, and interpersonal factors that inform healthcare access, quality, and utilization, concentrating on equitable patient, provider, and community hospital partnerships and shared decision making. Additionally, her interests include innovations and participatory technologies to advance sexual and reproductive health equity, participatory action research, and evaluation of community and hospital-based interventions in SRP health, circular development, and evaluation. Currently, Dr. Scott is an assistant adjunct professor in the UCSF Family Healthcare Nursing Department and the director of the CMQCC California Birth Equity Collaboration. In collaboration with the National Birth Equity Collaboration and Alliance for Innovation and Maternal Health, she serves as the CMQCC Director of Mother's Voices Driving Birth Equity. I present to you Dr. Karen Scott.
Thank you. And so today I'll be talking about advancing cultural rigor and hospital births and perinatal quality improvement, the sacred birth movement. In the last 12 months, I served as the maternal quality care improvement expert for Black Mamas Matter Alliance, for Merck for Mothers, Safer Childbirth Cities. And today I'll offer one set of perspectives and a few possibilities to reimagine quality improvement, research, policy, service provision, and education. So I always like to begin my talks with contextualizing who I am so the audience can get a better sense of my intentions, but also my intended impact of what I hope this talk will do for you and those who watch it after today. So I'm a Southern born and raised Black woman from East Nashville, Tennessee, prior to gentrification. My education from 5th grade to completion of medical school is grounded in the liberal arts. Therefore, I'm a grateful, enthusiastic, lifelong learner. I do believe this is the way. I also identify as a proud reproductive justice avenger, a Wakanda healer, a Yoda follower, a Care Bear hugger. So this time during the pandemic has been really difficult. I also identify as a crunk public health scholar and an applied epidemiologist. And most recently, I'm also going by a health systems transformer. I'm celebrating 19 years as a community-based trained and serving OBGYN with about 18 months in the academy. And my main purpose is to advance cultural rigor through the operationalization of Black feminism, reproductive justice, and research justice in participatory quality improvement science, practice research, and interprofessional education and training. So during our brief time together, I will situate perinatal quality improvement in the afterlife of slavery, demonstrating the duality of Black birthing narratives and community wisdom in two ways: data as evidence and data as an interpretive tool using cultural rigor. So I hope that today, that at the end of this presentation, you'll be able to explain the limitations in closing the perinatal death gap between Black mothers and birthing people and other racial and ethnic groups. That you'll be able to utilize 3 frameworks to reimagine the lived experiences of Black women and people in society and in hospital births. And that you'll be able to explain the value of Black birthing narratives and community wisdom in measure development, in QI, and hospital performance evaluation, with an emphasis on the participatory patient-reported experience measure of obstetric racism, also known as the PREM-OB scale. So I like to start with where we want to go, a place of promise, power, and potential. So sacred birth is a radical attitude towards human birth, specifically Blackness, Black bodies, and Black births, that regards all birth activities as fundamentally normal, healthy, spiritual, familial, magical, transformative, erotic, communal, emancipatory, and power activating. Sacred birth encourages diverse and inclusive birth pleasure, practices, care, spaces, options, partners, communities, and experiences. The sacred birth movement advocates for safer, respectful, dignified, high-quality participatory birth care, conditions, experiences, outcomes, and improved workforce diversification and development, sustainability, and restoration of Black midwifery care and Black doula support models as part of its campaign. And in the spirit of transparency, I want to share 4 truths to demonstrate our beliefs about and feelings for Black people. We hold these truths to be self-evident, that we believe, trust, value, and adore Black people, women, and mothers. Black people, women, and mothers are worthy. We protect, prioritize, cite, and amplify Black women's people's voices, intellectual thoughts, lived experiences, and political activism. We activate and advance the power and potential, not pathology, of Black people, women, and mothers, and our given and chosen kin. Despite state and national quality improvement initiatives, clinical safety bundles, technological advances, and social protections, including safe motherhood initiatives, hospitals do not keep Black women safe. Hospitals willfully watch the death gap persist or widen between Black mothers and birthing people and other racial and ethnic groups in some locations or for specific conditions, experiences, or outcomes. And when we look at the various factors and actors that create, maintain, or exacerbate the death gap and near-death gap, we must address each of the areas that you see on the screen. Number 1, ethics. In order to address the existing gaps in knowledge construction, prioritization, and dissemination, we first must obtain an ethical understanding of the U.S. experience by situating the racialized clinical and social phenomenon of birth, specifically hospital births, within both a temporal and spatial context, understanding the historical and contemporary threats to achieving and advancing sacred birth, racial equity, and reproductive justice. We must establish very clear boundaries between what is right and wrong and what is just and unjust. Number 2, leadership. We must abstain from associating whiteness in terms of knowledge, rigor, relevance, responsiveness, and revelation. We must also abstain from censoring clinician experts and data scientists as the only ones qualified to drive innovation and transformation. And on a daily basis, we must interrogate and then dismantle the deep-seated assumption that the vision for Black birthing, liberation, equity, and justice lies with the engineers, benefactors, and transmitters of our oppression and harm. And number 3, knowledge. The existing leaders at the state and national level lack the necessary language, knowledge, training, and lived experience, including expertise or community trust, to operationalize a community-informed, anti-racist, and Black people-focused, reproductive justice-centered praxis in QI practice. Thus, we must shift the power of knowledge construction, incubation, acceleration, disruption, transformation, and dissemination from traditional data scientists, physicians, and a few nurses to Black mothers and birthing people, Black women community leaders, and Black women scholars in public health, social sciences, humanities, legal studies, creative arts, and political activism. And number 4, science. How many more Black lives will we lose? How many more Black families will we harm and fail to keep safe along this journey to motherhood and parenting by investing in quality improvement or QI science that lacks cultural and scientific rigor? QI science generates local wisdom and generalizable or transferable knowledge with robust, established research methods applied in very highly pragmatic ways. Even still, I have continued to express concern for the lack of rigor, patient involvement, community participation as funded decision makers and experts, again, in the humanities, social sciences, public health, activism, and the arts. Our existing QI science relies on non-standardized and unverified data and poorly designed activities that lack historical context, relevant theoretical frameworks, and robust methodologies that illuminate the oppression, the resistance, and the resilience of Black women's and people's lived experiences. Number 5, truth, trust, and transparency. If we can interrogate and disrupt and transform QI ethics, knowledge, leadership, and science, then perhaps we can lead with truth and transparency that racism, and not race, is the risk factor for persistent death gaps or or near-death gaps, and racial inequities in severe maternal morbidity. By leading with truth and transparency, then perhaps we can reimagine or reestablish a new trust in the experience of seeking help or health care during pregnancy, labor, childbirth, lactation, and postpartum, and beyond, that makes equitable options and opportunities for optimal expectations, boundaries, and reciprocity. Number 6, only with truth, trust, and transparency can we transform the culture of health services provision through dignified and equitable community participation and partnerships that avoid exploitation, tokenism, decoration, and manipulation of community. We must always assess the decision-making and funding mechanisms, as well as interrogate the inequitable distribution of power, risk, benefits, and burdens for participating in QI among community systems and funders. And finally, number 7, outcomes. The prioritization of individual level measures, such as clinical and pathology related outcomes identified in big administrative databases, at the exclusion of structural and process measures, weaponizes the lie that race is a biological construct against Black women's interests, humanity, and liberation. Thereby, the utilization of Blackness and Black womanhood evolves into a reproductive and perinatal quality improvement process, practice, and policy of risk identification, stratification, reduction, and or elimination through anti-Black, sexist, and racist or misogynistic pathways that silence, stigmatize, and suffocate Black birthing power, resistance, and resilience. So I invite you to learn more about one of the primary drivers of the perinatal death or death gap, the philanthropic industrial complex. So in 2020, in this essay, my co-authors and I examined the belief held by many philanthropists that the most structurally marginalized communities lack an existing repository of knowledge, historical and contemporary knowledge to address social and health inequities. In so doing, we outline how philanthropy, especially in perinatal and reproductive health services, research, and quality improvement, has contributed to the diminishing political power, legitimacy, and effectiveness of community voices in leadership and reproductive equity through research injustice, cultural arrogance, philanthropic redlining, and community harm. We justify the need to elevate a hybrid praxis of Black feminism and reproductive justice as the new ethical standards for philanthropic accountability. Then we call upon our funders to embody the equity they aspire to see and build through the operationalization of cultural rigor to advance structural equity and racial justice and to sustain community engagement and research. For the purposes of this presentation, I want to briefly share this concept and implication of philanthropic redlining in perinatal QI. So if we are to address this crisis with radical curiosity and courage, the philanthropic sector must re-examine its role in promoting a status quo that prioritizes a limited set of disciplinary and demographic expertise to a chosen few, at the exclusion and erasure of Black community members, activists, artists, and scholars. Specifically, the philanthropic redlining is a discriminatory practice of inequitable distribution of philanthropic funds combined with neglect of justice-centered Black-led institutions and is fueled by discriminatory notions that Black-led institutions are ineffective, inferior, and fraudulent. The consequence of historical philanthropic redlining is that as little as 8% of foundation funding goes to people of color and 1% to Black community, reinforcing the belief and practice that the social change within the Black community must be led by white governed institutions. Thus, the byproducts of ongoing philanthropic redlining, as you see on the screen, are cultural arrogance and community harm, and the devastating consequences manifest in 4 key areas that continue to delay radical curiosity, care, and change in perinatal quality improvement and health services provision, such as the lack of shared knowledge, acknowledgement, perspectives and understanding, lack of shared language and meaning, lack of effective, meaningful, and sustainable collaboration and coordination across and within organizations and health and public health systems, and lack of infrastructure, processes, and practices for collective assessment, alignment, and advancement. Philanthropic redlining results in funding Black-led teams under what we call white expediency and white urgency. So white urgency is the quality of being important that requires swift action that advances white people and those proximal to whiteness while simultaneously disadvantaging and harming Black people and those amplifying Blackness. And white expediency is the quality of being convenient and practical, despite possibly being improper or immoral, resulting in differential risk, barriers, burdens, and benefits, particularly among those who are amplifying Blackness. So by now, I hope that you are better able to describe the challenges in addressing racism and racial inequities using traditional perinatal quality improvement initiatives. Given to date, no prior perinatal quality improvement state or national QI initiative has integrated the scholarship of Black women, historians, anthropologists, legal scholars, public health experts, lactation specialists, and reproductive justice activists. So consequently, all white, usually clinician or data scientist only teams are then believed to be the only scholars capable of conducting robust research and driving innovation. This one decision alone creates a cascade of events resulting in the construction and dissemination of knowledge that ultimately reproduces and reinforces disturbing narratives that Black bodies are subhumans and Black lives are unworthy. So not only must we hold philanthropists and funders accountable, we in medicine, nursing, healthcare, and public health can no longer deny the historical and contemporary existence of reproductive and perinatal apartheid in the United States health systems. In 2018, I described the meaning, manifestation, and mechanisms of action of this particular type of apartheid. Meaning, reproductive and perinatal apartheid describes a system of racial and ethnic separation rooted in a hierarchy of value, power, potential, knowledge, and participation based on skin color, resulting in the pursuit, provision, and proliferation of safe, respectful, dignified, responsive, high-quality reproductive and perinatal care and experiences during pregnancy, labor, childbirth, and postpartum for maybe one or two dominant groups in the United States. The specific type of reproductive and perinatal apartheid is then manifested in differential ideologies, policies, and practices within and across different systems, such as healthcare, housing, education, judicial system, law enforcement, law, workforce, and family, and differential quality, provision, and proliferation of care, opportunities, and options, differential funding opportunities, structures, and mechanisms, differential access to and utilization of care, differential assessment, diagnosis, treatment, and follow-up, differential literacy, health literacy, sexual, reproductive, and perinatal literacy, and differential maternal and infant mortality and morbidity rates. This list is not exhaustive. Reproductive and perinatal apartheid are operationalized through mechanisms of actions that privilege one universal notion of womanhood, humanity, femininity, sexuality, reproduction, birth, and motherhood or parenthood, while denying, constraining, and undermining the self-determination, expression, and development of a less dominant group. In the absence of reproductive safety, agency, and dignity among structurally excluded, marginalized, or minoritized groups. Existing ethics, theories, methods, and dissemination practices in perinatal QI were not working for me to eliminate the perinatal death or near-death gap. So I stepped outside of medicine and QI and looked at social sciences and public health and applied social science to reflect what our Black feminist anthropologists and other scholars in the humanities have always known. I needed a model of scholarship, humanism, activism, and infinite love for Black people, women, and mothers that recognize intersectional oppression, harms, and control, while at the same time illuminating our resolve to push through and rise up. So I reimagined and redesigned QI science, practice, and research after the late Dr. Leith Mullins, the Harlem Birthright Project, and Dr. Donna Ian Davis's Reproductive Injustice. To quote Dr. Mullins, the story of Sojourner Truth has become an important symbol of both the constraints and activism characterizing the lives of African American women, It conveys a message about the intersection of racism, classism, and gender oppression, as well as the dialectic of oppression, resilience, and resistance. The Sojourner Syndrome provides us with a broader understanding of why Black women and men die prematurely at younger ages and have higher rates of morbidity and mortality for most diseases compared to white women and men. The Sojourner Syndrome also offers an intersectional approach which emphasizes the necessity of examining how racism, sexism, and classism operate in the lives of Black women and how they interact to produce health effects. Dr. Mullen's scholarship informed me of different methodologies to implement during my QI research in order to illuminate the complex and dynamic lived experiences of Black women within and across various roles, responsibilities, and relationships in society outside of the role of patient in hospital settings. In the design of our work, we prioritize participant observation, individual case studies, focus groups, ethnographic questionnaires, and a strategy of community participation. Our third explanatory framework is Dr. Donnie Davis's explanatory framework of obstetric racism, described first in an online publication in December 2018 to your left, and then later in June 2019 in her book on your right. Obstetric racism gives the field of perinatal quality improvement a novel and nuanced explanatory, multifactorial, and multidimensional framework for describing the mechanism of actions, including the people, perspective, policies, power, places, processes, pathways, and procedures that interact directly or indirectly to produce stressors, such as diagnostic lapses, neglect, dismissiveness, intentional pain, or ceremonies of degradation from multiple sources that can contribute to a single adverse outcome, such as a near death or death from unnecessary low-risk primary cesarean births, postpartum hemorrhage, or severe hypertensive crises. Alternatively, obstetric racism also explains how one single stressor, such as performing a cervical exam on a patient with the intent of initiating labor by stripping the membranes without informed consent, can lead to 27 hours of labor, a cesarean birth for arrest of active labor, a post-operative infection, and NICU admission of the newborn. And these are examples of stories in Dr. Davis's book on your right. Obstetric racism offers us then this new explanatory framework that situates modern day clinical and research protocols, practices, procedures, programs, and policies, specifically the language, narratives, and archetypes of Black women in the afterlife of slavery. And I quote from Dr. Davis's book: conceptually, the afterlife is not simply a consequential expression of inheritable trauma. In other words, I am not arguing that the afterlife of slavery has resulted in an epigenetic phenomenon, although it may. Instead, I argue that one way Black women's prenatal experiences, pregnancy and birthing, can be understood as an extension of tropes, practices, and beliefs that can be traced back to antebellum and postbellum periods. What we see is that racism is continuously recalibrated, a racism that is a reinterpretation of enduring processes of slavery. One may think that comparing the United States hospital birthing experience to slavery is extreme. Well, listen and see the words of a Black mother in Los Angeles to your right in the upper corner, who participated in our 2019 focus groups that explored Black birthing preparation, expectation, and experiences. Our participant had no prior knowledge of Dr. Davis's scholarship. And she says, you push out the baby and then you go back on the fields and you keep picking the cotton. Decolonizing the dominant ethos and ethics in perinatal quality improvement requires a dismantling of this hierarchy of power and dominance as structured by the medicalization and professionalization of birth. Smashing the hierarchy liberates and then shifts this power from the colonizer to the colonized, that then catalyzes two important events: the redistribution of leadership, knowledge, and science, which then influences outcome selection and prioritization, as well as the mobilization of structurally minoritized and marginalized voices and scholarship to the epicenter of knowledge construction, incubation, acceleration, disruption, transformation, and dissemination. This quote also highlights the limitation in QI knowledge, science, and data that prioritizes outcomes-only benchmarks and metrics. Examining quality of care through clinical-only outcomes establishes two lies as truths. Number one, Blackness is biologically inferior, particularly Black women are broken, deficient, and or more vulnerable or susceptible to disparate birth outcomes. And number two, the absence of clinical pathology signifies the presence of perinatal equity. In the next example of a Black birthing narrative, a Black mother shared her post-birth reflections after she experiences a vaginal birth of a healthy term, normal weight infant that does not require admission into the neonatal intensive care unit and an infant who latches so well after birth. This outcome would meet the benchmark for success for a typical hospital. For a typical hospital, data scientists, QI experts, clinicians and administrators to assume that racism did not play a factor in this patient's care, given 100% score on all these key performance indicators. However, a patient-reported experience measure designed for, by, and Black mothers and birthing people to supplement outcome, process, and structural measures would highlight the many different forms of abuse and violence that the medical personnel and potentially any personnel within medical institutions and health systems perpetuate against Black women. One of our Black mothers and birthing people shared her feelings about her hospital birth experiences during our 2019 focus groups after such a positive and healthy birth experience based on standard hospital performance indicators. And she sat holding her baby during the repair of the perineal laceration of the tear in the vagina and vulva area. And she says, though he put me back together, I still don't feel whole. Therefore, creating perinatal equity dashboards to stratify data by race will not save Black women. It will not illuminate the particular kinds of social and clinical interactions, behaviors, and language that perpetuate acts of degradation, dehumanization, violence, and abuse that lead to the wounds not detected by outcomes-only data. As inspired by Black feminist anthropologists, Dr. Mullins and Dr. Davis, we applied a Black feminist praxis to examine the power differentials within the medical industrial complex, specifically perinatal quality improvement activities and impacts. So in the summer of 2019, we set out on a journey to disrupt and deconstruct 7 key contributing factors to understanding the phenomenon of childbirth hospitalization from admission to discharge through the perspectives of Black mothers and birthing people. So to date, no validated participatory patient-reported experience measure of obstetric racism, also known as the PREM-OB scale, exists that characterizes the impact of the quality of hospital-based perinatal care on the patient experience as defined for, by, and with Black mothers and birthing people in dignified and equitable partnerships with Black women-led community-based organizations and Black women scholars. The 3 aims of the Sacred Birth Study were to validate a PREM-OB scale for field testing among adult Black birthing, among Black identifying mothers and birthing people who gave birth to a live newborn across the United States, to develop a community-centered, person-focused, hospital-based quality improvement toolkit for hospitals, health plans, and other stakeholders with Black women-led community-based organizations, and to examine the association between the PREM-OB scale, COVID-19 pandemic hospital responses, and birth outcomes and experiences, with a key focus on birthing alone or in isolation, patient-child separation at birth and immediate postpartum, infant feeding supports and options, including human milk, donor human milk, and formula. With the existing models of perinatal quality improvement knowledge, science, and practice, and research no longer served me in this work, I developed a model of participatory quality improvement research after the theoretical and methodological approaches described in Dr. Leith Mullins' The Harlem Birthright Project and Dr. Davis's book, Reproductive Injustice. We utilize a mixed methods, multi-cohort participatory approach that again shifts the power of knowledge, generators, incubators, accelerators, transformers, and disseminators, from traditional QI experts to the left to Black mothers and birthing people and Black women-led community organizations, and establish equitable and dignified partnerships with Black women scholars, artists, activists across disciplines, geographies, and generations, as described and listed on your right. Our participatory quality improvement science practice and research model requires completion of a series of easy 1, 2, 3 steps. Number 1, name the problem. As you see, we've named it, this persistent death gap. Number 2, define the problem through the Black feminist intellectual thought and political activism. As you see, we've described those 3 frameworks. And number 3, design and implement methods to measure, monitor, and modify the problem and mobilize action based on patient narratives and community wisdom. In our study, we focus on 2 key components. Black women-led serving community-based organizations and transdisciplinary, transgenerational scholarship of Black women in these various roles, and our co-conspirators, as well as the PREM-OB scale and the virtual quality improvement prioritization by affected communities, also known as the VQPAC. Again, in our scholarship, as well as in Dr. Davis's scholarship, Dr. Davis asserts that obstetric racism serves as a threat to positive birth outcomes. And in our participatory QI research model, we assert that obstetric racism is a threat to sacred birth. I developed the concept of cultural rigor to expand the value of cultural humility beyond interprofessional education and health services provision. Cultural rigor offers 4 modalities for institutional recognition and mitigation of cultural arrogance, philanthropic redlining, and community harm. Initially, I applied cultural rigor to the practice of philanthropy. I will now apply cultural rigor to my current actions to decolonize, disrupt, and redesign perinatal quality improvement. So as a social movement, and you'll see this on your right, cultural rigor creates the necessary long overdue paradigm shift in the hierarchy of leadership and knowledge generation, incubation, acceleration, dissemination, disruption, and expansion. And I do repeat that many times throughout this talk so that you're really grounded in who gets to say what knowledge is valued and what knowledge gets to be studied and examined and transformed. Self-determination of Black mothers and birthing people, including Black birth workers, community leaders, scholars, artists, and activists, are recognized and restored through Black feminist intellectual thought and political activism in perinatal QI. So reimagining birth for us is a righteous act of rage, resistance, resilience, liberation, and love. Cultural rigor as an analytic framework demands that the scientific method, philanthropic giving, and quality improvement triad of science, practice, and research build the capacity for the researched to serve as the unfettered architects, incubators, and accelerators of their own radical imaginations, connections, and destinies. By utilizing reproductive and perinatal apartheid, sojourner syndrome, and obstetric racism as the frames by which we examine, explain, and then transform the phenomenon of birthing while Black in U.S. hospitals, we redesign quality improvement science, practice, and research with trust, truth, transparency, reconciliation, and reciprocity. So as a praxis, cultural rigor mandates the operationalization of Black feminism, reproductive justice, and research justice through the implementation of our soon-to-be validated patient-reported experience measure of obstetric racism, aka the PREM-OB scale, and the virtual quality improvement prioritization by affected communities, or our VQPAC protocol. And finally, as a vision for racial justice and reproductive and perinatal equity, cultural rigor creates optimal options, conditions, and opportunities for engaging the full and prime potential and power of individuals, communities, and systems where radical imagination and innovation and care thrive. Voices, values, and beliefs are also better aligned, integrated, and reflected back to the community. Our vision for innovation and transformation in perinatal QI is the replication and expansion of sacred birth QI model. In this slide, we share illustration of how the arc of cultural rigor transforms us from defining and contextualizing the program, from defining and contextualizing the everyday lives of Black women by grounding the existence, experience, and expertise of Black women, mothers, birthing people, and our community in reproductive justice praxis, reproductive justice, and research justice to the patient experience, which is deeply embedded with a circle or a network of radical and unapologetic care and love, even in the absence of racial and cultural concordance. So I'm very excited about our growing body of research and the translation of Dr. Davis's explanatory framework and obstetric racism, and how we're translating her framework to novel and nuanced perinatal quality improvement tools, techniques, and trainings. And I invite you to study our latest 2021 publications in American Anthropologist on your left, which came out last month on March 14th, and Feminist Anthropology on your right, which actually was published on April the 11th, the first day of Black Maternal Health Week 2021. I will now provide one example of domain meaning, measure, and narrative. And I invite you all to go on our study website to view our February 25th online conference, where we briefly described all 7 theorized patient-identified quality of care domains. So the full current body of work is now in review. So for our first theorized domain, we start with S in sacred, which is the acronym that represents all the domains of our theorized model here. Black mothers and birthing people define safety and accountability as protection and security, and not always being in a state of fear, flight, fight, or freeze. Black mothers and birthing people feel that safety and accountability show up in hospital care as attentive, available accountability, showing Black mothers and birthing people feel that safety and accountability show up in hospital care as attentive, available, and responsive nurses and nursing staff and physicians, and as feeling seen, heard, affirmed, cared for, and included by the healthcare team. So I will share a birthing narrative by a Black mother that demonstrates how the domain of safety and accountability is violated through the words and lived experiences of a Black mother. Our Black mother is a 27-year-old Our Black mother is a 27-year-old Black Jamaican-born heterosexual woman married who earned a doctorate degree or medical law degree with full-time employment and an annual household income of $200,000 or more, diagnosed with severe preeclampsia with a term vaginal birth. She shared the following as a free text during our survey validation study. I felt like my birthing experience was akin to the stories that many Black women recount. I was in the hospital for 2.5 days in labor. I only had one Black nurse. That was the only time that I felt like someone actually listened to me and cared about my experience. I was left alone for hours and later found out that this was unacceptable by the doctors. Their actions led to both myself and my baby becoming ill. What was almost a stillbirth, a stay in the NICU where my baby had to be cooled down to slow down his brain activity in order to prevent further brain damage. This all occurred because I was left to naturally have a baby that was far too big when I should have had a C-section. The doctors left me to tend to someone else and seemed to have forgotten. They never came back, not until things were at a dangerous point. This was a horrible first birthing experience. And because of this, I do not think I want to have any more children. I do not know if it is worth the risk of my life and the life of my future child. Now we will spend the remaining time sharing preliminary findings, and because our full body of work is under review, we explicitly ask and expect that you will not duplicate, share, or edit any information we provide today without our explicit enthusiastic consent and support. The patient-reported experience measure of obstetric racism represents my intellectual property as a survey developer and owner. The scale is protected and is registered with the Library of Congress and protected under copyright law, and the PREMOBI scale is trademarked. The Sacred Birth and Time of COVID-19 study is a Black women-led team of Black women scholars in partnership with our academic co-conspirators, representing diverse experiences and areas of expertise spanning from multiple generations, institutions, and disciplines in anthropology, in nurse midwifery, epidemiology, obstetrics, family practice, lactation education, doula support, obstetric hospitalist medicine, community health advocacy, and activism. The common thread among the Sacred Birth researchers is our lived experiences, areas of expertise, or formal training in public health with a master's or terminal degree. We also represent diverse geographic borders across the United States, including Northern and Southern California, Illinois, Ohio, Tennessee, and New York. Our state lead community-based organization and community co-investigator is the California Black Women's Health Project. Sacred Birth's perinatal quality improvement innovations are developed and supported by a group of 14 Black women-led community-based organizations, also known as our community accountability partners. And our funders include the California Healthcare Foundation, the Tara Health Foundation, and an anonymous donor. Our communications, marketing, and design team is also Black women-led and operated. I also want to lift up the amazing work of our graphic designer and doula, Cheyenne Varner. I highly encourage you to visit and purchase illustrations and infographics from her company, The Educated Birth, as one strategy to increase the visibility of Black and brown bodies with diverse and inclusive skin hues, body shapes, body sizes, broad noses, wide curvy hips with kinky, curly, big hair, and Afro puffs and full lips. The Virtual Quality Improvement Prioritization by Affected Communities, also known as the VQPAC, is an adaptation of the research prioritization by affected communities called the RPAC. And we developed and tested this VQPAC protocol, which applies Black feminist ethnographic methodology to describe different forms of resistance and resilience that Black women community leaders adopt to mitigate the dimensions of obstetric racism, empower inequities that emerge from supporting Black mothers and birthing people during hospital births. We enrolled a total of 24 participants from 15 different Black women-led organizations across California who support Black women and people experiencing pregnancy, birth, and lactation. And to your left, you'll see that our community leaders identified 74 and prioritized 44 potential perinatal, social, cultural, quality improvement topics across the PRIM-OB scale domains. Then they further prioritized quality improvement topics down to the top 2 mitigations for each domain of the scale, as demonstrated on the slide here. The VQPAC offers potential mitigations against obstetric racism beyond pathology-centered risk reduction strategies described in the existing QI safety bundles through the intellectual thought and political activism of Black community leaders. Our Sacred Birth referral partners included 17 hospitals, 2 health centers, 2 health plans, and 1 national community partner. In this slide, you see a map of the United States with red dots representing the numbers and locations of our study participants in each state. We released the scale on October 19, 2020, during the pandemic. Study enrollment successfully closed January 15, 2021, and data collection successfully ended January 31st, 2021. We achieved 81.5% of our goal, which is 815 of 1,000 enrolled Black mothers and birthing people who birthed live babies in hospital settings during the pandemic, and then who completed the scale after hospital discharge using any electronic device with Wi-Fi. Our study participants represented 34 states and DC and 348 hospitals across the United States. Mississippi and my birth state, Tennessee, achieved the largest study participation outside the study host state of California. We will share some demographic data about our study. When looking at relationship status and cohabitation status, about 1 in 3 identified as married and living with their partner, while 1 in 4 identified as single, and about 15% of our single Black mothers and birthing people also live with their partners. We wanted to show a representation of the infants, children, youth, young adults, and adults living in the households of Black mothers and birthing people, but especially when we share information about the household income based on the people in the home and education level of our study population. The 2 largest groups are children aged 0 to 5 years and adults aged 26 to 44 years. Here in this slide, representing total household income before taxes and deductions, we see what Dr. Mullins described in the Harlem Bright Project around the context of the fact that there is an inequitable economic return on investment for Black women's education and occupation. So in our study, 1 in 3 were married, living with a partner, and 1 in 4 were single, and 1 in 6 were single living with a partner. In our study, 1 in 4 Black mothers and birthing people earned a bachelor's degree, and 1 in 6 Black mothers and birthing people earned a master's degree. And also 1 in 2 Black mothers and birthing people were working 40 or more hours per week. However, 1 in 3 households had income less than $25,000. And 1 in 2 households had incomes less than $50,000. So again, showing this inequitable economic return on the investment for Black women's labor and education. We also want to lift up the voices, narratives, and lived experiences of Black birthing people who may not all identify as women or heterosexual. Part of our Sacred Birth vision is to honor the diversity of how we seek pleasure, form partnerships, and build chosen or given family. In this slide, our data demonstrated that about half of our participants qualified for parental or medical leave, while the remaining half did not qualify, with a small proportion reporting they were unsure if they qualified for leave. Among the 361 participants who did qualify, a little more than half of our participants reported 7 weeks to 3 months of leave. We do acknowledge that not knowing if the leave was paid is a limitation in our analysis. We see that hospitals performed a cesarean birth on a little more than 1 in 3 Black mothers and birthing people in our study here, with 53 participants reporting a prior cesarean birth and 19 participants who reported a vaginal birth after cesarean or a VBAC. And with these data, we were able to estimate a 35.8% VBAC success rate in our sample. We do acknowledge we do not know the number of prior cesarean births or whether the cesarean birth was a primary or repeat cesarean birth. It was also important for us to contextualize the lived experiences, need, and priorities of Black mothers and birthing people, and then to identify and describe the sources utilized to fulfill their needs, community, hospital, or both. In this bar graph, you will see columns in red that represent community and in orange to represent hospital. Underneath each column, we list the need. For the sake of time, I want to highlight that about 7% of our study participants reported needing help to reduce violence in their home, which we anticipated as the pandemic responses required people staying home in close proximity and in contact with violent perpetrators. We also observed that 43.2% of our educated and employed study needed assistance for food, and like 15% and 11% needed assistance with financial aid or housing, respectively. And here we use a visual aid to demonstrate with lots of color our patient-reported experiences of obstetric racism across 3 patient-theorized domains, where each item reflects a prior lived experience of 37 Black mothers and birthing people from our 2019 focus groups in LA and Oakland. Both survey items use the frequency 5-point Likert response scale. For these items, the directionality of less obstetric racism is determined by responses equivalent to almost never or rarely, with the red arrow pointing to your left, whereas more obstetric racism is determined by responses equivalent to always or often, with the red arrow pointing to the right. The increase in column height represents higher reported experiences for that response. Each color is associated with a specific survey item in a specific domain. And in this bar graph, red represents a survey item from the racism domain. And we found that 67% of Black mothers and birthing people often or always wished they had more information and support about lactation, breastfeeding, or chest feeding that was specific to Black mothers and birthing people. Orange represents a survey item from the communication and information exchange survey item, where 60% of Black mothers and birthing people often or always wish the hospital provided more information about possible complications during labor, birth, and postpartum, such as changes in blood pressure, blood loss, infection, postpartum depression. And in this bar graph, we see the results from 2 different survey items for 2 different domains. And these domains are autonomy and dignity, specifically around data. Both survey items use the frequency 5-point Likert response scale. And again, for these items, the directionality has shifted. The directionality of less obstetric racism is determined by responses equivalent to often or always, with the arrow now pointing to your right, whereas more obstetric racism is determined by responses equivalent to rarely or almost never, with the red arrow pointing to your left. And in this graph, we see that red represents a survey item from the autonomy domain. The hospital almost never or rarely assessed patient comprehension during informed consent or informed refusal by asking patients to repeat back or write down what they heard among 67% of Black mothers and birthing people in our study. That means autonomy was violated in every 2 of 3 Black mothers and birthing people in our study, which is associated with higher reported experiences of obstetric racism. And orange represents dignity and Blackness, specifically around data transparency. 81% of Black mothers and birthing people report that hospitals rarely or almost never shared their data on birth outcomes and reassured them about hospital-wide efforts to address racism in obstetric care. This lack of hospital transparency erodes patient trust and as well as demonstrates a disregard for valuing Black mothers and birthing people as worthy of recognizing the role of racism in care and sharing hospital strategies to mitigate obstetric racism and to advance safer, higher quality, and more humane and dignified care. So in conclusion, we are very excited about what we were able to do in a short amount of time. We are also very excited about the next steps in advancing the Sacred Birth QI movement to end obstetric racism through human-centered design approaches that are grounded in cultural rigor, focusing on the South and the Midwest, where we firmly believe is where the data reside. And so we're following our data that we learned from our 2020 Sacred Birth Survey Validation Study. And in our Sacred Birth QI movement, we will be focusing on 360-degree cultural shifts, where we are incorporating the lived experiences and expertise of community, of staff, such as environmental, security chaplains, of nurses, of midwives, of physicians in the role of supervisors and champions. We'll be hosting and curating large group trainings, small group coaching sessions, using illustrated clinical narratives, using animated video clinical narratives, as well as an array of effective clinical practice techniques for each of the domains, and using mixed methods of assessments and evaluation to better understand where hospitals are starting and where they need to go based on data from the patient, provider, staff, hospital, and neighborhood data. And we're hoping to build hospital and community capacity and capability of both diagnosing and dismantling obstetric racism through our 2-step process, using the first and only validated short and long form PREM-OB scale. And for more information, please visit our website, particularly in the area under hospitals, health centers, and health plans, for more information about the Sacred Birth Quality Improvement Implementation and Scale-Up Program. And here are a list of our references. And thank you so very much for your time and attention today.
Thank you so much, Dr. Scott, for a wonderful presentation.
Thank you for having me and allowing me to do the recorded session for you all.
Dr. Scott, thank you so much. And I do have a question for you. And that was really great to hear about the innovative QI model. And just curious if you gave hospital systems, if you share that data with hospital systems and what the feedback was.
Yes, so as I shared in the presentation, we had 17 hospital partners, and that basically meaning a partnership at the hospital referred patients, eligible patients, Black mothers and birthing people who birthed in 2020. Not every hospital had actual patient representation in our study. So for those hospitals who had representation, some hospitals had as low as 2 to as many as about 36. We scheduled technical assistant calls. So that is what the partnership allowed. So hospitals submitted a letter of support, and in return, we had at least 1 to maximum of 2 technical assistant calls. We shared the data that you saw today, but in more depth. And we did a comparative analysis between the national data and the data at that hospital. And the majority of the hospitals were shocked to see some of the information. For example, one hospital, this is a really good example. It's an example of why you can build it, but they still won't come. Meaning the sense that just that access in terms of just having a service provided in the hospital, if the way in which the service is promoted in terms of its approachability, its appropriateness, the messaging and the imaging that's used to create a safe, inviting, welcoming attitude and culture, that just because someone has a service, the community may not utilize it based upon how well they are received and how well they are invited to take part in that work. So there were hospitals who were shocked at the fact that they may have had, let's say, different programs that they thought were of use to the community, but the community wasn't actually utilizing it. So the slide where I show the needs and priorities of Black mothers and birthing people, you'll see that there were differences where hospitals provided the information or the resource, or the community did. So some hospitals who provided those same resources were in fact shocked that their own community were not utilizing the resources in their hospital. So it allowed for them to take a step back and reflect on how, on the messaging, the imaging, the staff, possibly moving beyond satisfaction and really looking at the impact of the care or the service on the experience, particularly in relationship to the expectation. There were some hospitals who knew they had challenges from some of their own survey data and, just folklore from the community. So there was a mixture, but definitely hospitals want to move forward. The majority want to move forward in that sacred birth quality improvement implementation and scale up program, because they realize they don't have the applied knowledge and skill to recognize how obstetric racism shows up in their cognitive clinical behavior in counseling and the decision-making, as well as the documentation in their charts that actually reproduces some of the harm.
Great. I mean, do you envision that? Go ahead, Tiff. Do you have a question?
No.
Yeah, and we'll ask one more question, and then we'll have to move on to. Don't want to keep the governor waiting, but do you envision that the scale can be used over time for hospital systems to improve and kind of chart their course and their outcomes?
So yes, that's the whole goal of it. Is not the scale is not being promoted as research to generate new knowledge for the sake of having knowledge. It's really used for quality improvement, implementation science. So the goal of the program is that supervisors and champions across those different levels of power, such as staff, physicians, midwives, nurses, even community, will be trained in what particular types of interactions, communication, counseling, decision-making, as well as the language that's used in a patient handoff and documentation. They will be trained in the theory, but also in the practice across the domains in the scale. So we're training supervisors and champions to the scale, and then system-wide, we will have an array of techniques that anybody that's a greeter to security to environmental to the clinician will modify their behavior and language in real time. And so we'll have a baseline, right scale. We will then train. Then there's opportunity to implement the techniques, and then we will evaluate the patient experience after there's an uptake of techniques to see how the culture changes, and we just keep doing that. So if there is no change in the systems diagnosis of obstetrical racism through the patient experience measure, then two things: either the training failed or people aren't actually implementing the techniques we trained them in. So it's designed for real-time evaluation and for quality improvement. So we continue to strengthen the system's capacity to change their behavior and language, but also build the community's capacity to understand and recognize when harm is being done.
Wonderful. Well, we can't wait to hear your results moving forward. And on behalf of Tiffany and the planning committee and the whole DHMIC, thank you so much for joining us from California.
Thank you so much.
Tiffany, thank you.
Thank you.
Greatly appreciated. Okay, it's now my great pleasure and distinct honor to welcome Governor John Carney to our conference. Governor Carney, thank you for your many years of support as Lieutenant Governor when we started, and now as Governor. And it's been an honor to work with you to improve birth outcomes in Delaware. So thanks again and welcome. I think, Governor, I think you may be muted. We can't hear you.
Okay.
There we go.
Can you hear me now? How about now? Can you hear me now? Still not yet.
No, we can hear you.
How about now?
Now we can hear you.
You can hear me now?
We can, yeah, thank you.
Well, I think the first opening was a good one, but everybody missed it. It's the old philosophical question: if the tree falls in the woods and nobody hears it, is there to hear it? Did it really make a sound? It's thank you for the opportunity to join you briefly this morning. Really, just to thank you for your good work. This issue, as you say, has been one that's been kind of front and center throughout my whole almost 30 years of public service. I remember it becoming an issue first for then Governor Mike Castle, and Governor Carper talked about and put efforts in place. And then the current Delaware Healthy Mothers and Infants Coalition was put together and have been doing great work. And for the longest time and until still today, infant mortality rates have declined in our state. There was a period where there was a little bit of an uptick. But the difference, the disparity between babies of color, women of color, and the general population continues to persist and obviously challenges all of us. Infant mortality and healthy mothers and infants is an initiative, is a challenge that we measure, and as we should measure all of our efforts in public health and public policy more generally. This past year has challenged all of us with the COVID-19 pandemic, a situation that is unprecedented for each of us. And never in our lifetimes have we seen this kind of global pandemic, not since the flu pandemic of the early part of the last century has the world been challenged with such a public health threat. We've learned a lot about COVID-19 and it's the way it spreads and how we can attack it and deal with it. And we've learned about ourselves and how we come together or not to address a public health crisis. We've learned what leaders do and our public health officials, Dr. Karyl Rattay, as the division director in particular, and her team at public health have really risen to the occasion. Sadly, we've also seen that the COVID-19 pandemic has laid bare health disparities that we've known existed for some time, not least of which is the health of babies and mothers that differ for women of color and white women. And so your work continues to be incredibly relevant and important for all of us. Frankly, it's a measure of our efforts to provide for healthy conditions for every one of the citizens of our state. And of course, the whole issue of differences and disparities in all kinds of things, in all kinds of areas, have been laid in front of us with respect to the relationships between communities of color and our law enforcement agencies through the Black Lives Matter challenges of the past year. And so your work is more relevant, more important than ever. And as your governor and as somebody who's been challenged with COVID-19 and bringing the people of our state together to get behind it, to lean into it, to do what's necessary to meet the challenge of COVID-19 and its spread. And for sure, we are doing that. And we're doing that because of cooperation. We're doing that because of the professional approach, the science-based approach of the Division of Public Health and all its partners in law enforcement and our hospitals and our healthcare providers. The same kind of effort, coming together effort necessary to effectively address infant mortality and the issues that you and the coalition do. And I'm just incredibly grateful to all of you for this work, continuing to meet this challenge, continuing to keep those rates trending in the right direction. Obviously, we're always challenged to make sure that we reduce the differences, particularly for women and babies of color, to make sure that they have the same opportunities. I came in as the last presenter was talking, and she said something that really rings true to me. The idea that if we build it, they will come, and that's not an assurance. That's not a given. Sometimes it's really a question. If we build it, will they come? And what are the things that we need to do to make sure that they come? And we have been challenged that with respect to getting Delawareans tested initially, and now getting Delawareans vaccinated to protect against COVID-19 spread. And our challenge has been across the board with our senior citizens and their limited mobility, the challenges that they face in accessing technology, in signing up for vaccines, with respect to communities of color, some of the hesitancy we see across populations. We are always challenged to think through, are the assumptions that we make about people's attitudes accurate, and do they ring true? And one of the things that I think I have learned is that some of those assumptions just aren't true. And that we always have to look anew at challenges, public health challenges and problems that are as longstanding as our efforts to address infant mortality in our state, going back as long as I've been in public service here in Delaware. So I don't know whether you were to have your award presentations, but I know at some point I'm supposed to present. I'm delighted to present an award. Dr. Karyl Rattay, I'll defer to you if this is the time to do that.
This is the perfect time. Thank you.
So I remember well when I was shortly after I was first elected lieutenant governor in 2000. And Dr. Rattay, I don't think was working in state government at the time. We're recognizing her today, and I have an award that I'm going to present that recognizes her as the longest serving state public health official in the United States. But it's more than just a long tenure. It's the incredible service and leadership that she has provided, particularly over the last year. I had a conversation back in 2001 with one of Dr. Rattay's predecessors as the director of public health. And I asked this physician, what was the thing that she was most concerned about? Dr. Rattay has heard me tell this story before. And she said she was most concerned about a global flu pandemic because she said we were due for one. And she was very concerned about it. I went to all of our emergency preparedness manuals to look up what we were putting in place there and the challenges that we might face and the challenges that were faced a century before in the pandemic in the 2017, 2018 period in time. And I became incredibly focused and concerned about hospital capacity. Dr. Rattay, remember going back to this COVID-19 when we first started this response back in March and April of last year, that I kept hearing that public health official and her concern ringing in my ears. Mm-hmm. But Dr. Rattay has been in this position, I think, for over 10 years. But it's this past year where she's really been called on to demonstrate the incredible leadership that she has during these months, with compassion, with professionalism, explaining and reaching people, the people of Delaware, where they are, translating the public health science in a way that's understandable to ordinary Delawareans. So this is a award that's being presented to Dr. Rattay for her long years of service. But for me, it's so much about the last year when she was called on to provide just incredible leadership and guidance to keep people of Delaware healthy and safe and alive. And we're not all the way home yet. We still have a lot of work to do. but I want to just thank her for her tremendous service. Present this award remotely, kind of indicative of the world that we live in, the COVID-19 world, and thank her for her tremendous service to the people of the state of Delaware. Congratulations, Dr. Rattay, and thank you.
I'm just so honored to receive this award from the governor and from my friends and colleagues at the DHMIC. I'm really, really happy to be with you all today. My friends, my colleagues, I feel like I'm with my people. And this year has been quite a crazy year for all of us, right? And I miss you all because I have not been able to focus as much on the work of the DHMIC this year. But as those who know me, you know how deeply passionate I am about maternal and child health issues and about equity in our state and addressing social determinants of health and the years and the impacts of structural racism on our moms and our babies. And we've all seen it play out during this pandemic. But I'm just so grateful to all of you for continuing to do the hard work that you are all doing. And while we've seen some improvements in infant mortality rates, we also continue to have unacceptable disparities. But I think there's some really good news right now. I feel and I see some momentum, some excitement, some enthusiasm that I've certainly never seen as it relates to addressing these issues. And maybe the pandemic has really helped coalesce some people together. Certainly all of the impacts of policing that we've seen, the Black Lives Matter movements, but all of the work that you all are doing, the DHMIC, the focus on social determinants of health, Dr. Paul and Tiffany and Susan and others, Representative Minor Brown and Rita Landgraf for chairing the Social Determinants of Health Committee, individuals who are advocating like we've never seen before, advocating for people of Black and Brown communities, groups that have been coming together, groups that have been together for a while, like sororities, organizations, but also people who have been coming together in an ad hoc kind of way, and really leading change in our state. It's so exciting. It's so exciting to see the work of Healthy Communities Delaware. It's so exciting to see that, this pandemic is really bringing some resources to a division of public health that we haven't seen before to address social determinants of health and bring additional professionals like community health workers to work with our communities. So again, we just are so excited. I feel like in the midst of an incredibly difficult time, the time is now to really move this work forward. And this is the work that all of you have been working on for years. I feel like, we're really gaining some traction. So I thank all of you today. The conference today is just amazing. And I just so grateful and amazed by the work that you all are doing and finding solutions and really addressing the complex issues around social determinants of health. And so every year at the DHMIC, we get to announce awards to an individual and an organization that's been working hard for mothers and children in Delaware. See, now's the part that I thought I was really doing today, which is I'm announcing our awardees, which we have every year. But what's exciting is that, there's a lot more awesome individuals and organizations to select from now. And this year, as equity gaps have been magnified, we are reminded how vital it is for us to remove obstacles to good health. Obstacles like poverty and discrimination and the lack of access to good jobs and with fair pay, housing. These are all so important to moms and babies and Delawareans being able to achieve the health that they and their families deserve. So the Community Health Champion Awards, they stand for diversity and social justice and equality. And they're our way to say thank you to the individuals and organizations who are making changes in our communities. So first, it is my great pleasure to get to announce the individual champion and health winner, Shané Darby. Shané is a courageous advocate for maternal health, especially within communities of color. To address health inequities that Black mothers face every day, Shané founded the statewide nonprofit organization, Black Mothers Empower. And as a Black woman, a mother of 3 girls, and an advocate, Ms. Darby genuinely understands the challenges that Black women face when trying to access and receive health care. And as she shares, she became pregnant with her first daughter during her senior year in high school. And despite challenges, Ms. Darby continued her education, earning her bachelor's and master's degrees from Temple University. Motherhood and her passion for equity motivated her to create Black Mothers Empower, to empower Black mothers by raising awareness and providing education. Shané Darby works tirelessly to build awareness, provide educational programming, and empower Black mothers by raising their voices and concerns and advocating for legislation to address racial inequity among mothers in her community. The nonprofit also empowers Black mothers to advocate for issues such as understanding the impact of implicit bias in healthcare services, doula care before, during, and postpartum, and taking action to improve health access and response for Black mothers and their children. Please join me in thanking Shané and congratulating her on this award. And Shané, are you here with us? Would you like to say a few words? Shané is not here with us, and so hopefully she's gaining the positive spirit from all of us and thanking her. And next time you see her, please make sure that she hears from all of us how grateful we are. So let me now pivot to our group champion and health winner, which is, I'm so happy for Class C to be receiving this award, the Community Legal Aid Society. And I know Dan Atkins is here. Dan has just been such a great champion and a part of DHMIC work for years now. Class C provides free legal services to vulnerable populations to help them address social determinants of health. For example, Class C works on issues to improve housing conditions, prevent homelessness, obtain protective orders for survivors of domestic abuse, and many other things. Class C helps immigrants to obtain permanent residency and ensures that low-income families have food and income benefits. Much of the work that they do, housing, public benefits, domestic violence, affects health, as we all know. And Delawareans can't be healthy without a safe home, food on the table, and safety net benefits. Class C works closely with many agencies that are addressing social determinants of health, including the Division of Public Health. Class C's efforts to support high-risk pregnant women contribute to the state's work to drive down infant mortality rate and improve the health and well-being of women and their children. So, Dan, it's really great to see you. Congratulations to you and to Class C.
Thank you so much, Dr. Rattay and Governor. Well, first of all, I can't tell you how excited Class C is to receive an award at the same time as Dr. Rattay and Councilwoman Darby, who we consider allies in the struggle for racial and economic justice here in Delaware. Class C's enjoying its 75th anniversary this year. And I think it's fair to say that our understanding of poverty and justice has evolved over the last 75 years. And we now have come to realize that there's nothing natural about poverty and inequality. It's essentially the result of affirmative choices we make to act or not to act, to pay people living wages in safe working conditions, to guarantee health care, to provide adequate and affordable housing, or to ensure no one is hungry. 8 years ago, there were 6 key health equity champions in Delaware that had a vision. And these individuals included Robert Locke, David Paul, Mawuna Gardesi, Crystal Sherman, Leah Woodall, and Dr. Rattay. And they worked together to ensure that Delaware was going to provide high-risk pregnant women with free legal services where and when they received their prenatal care. 8 years later, the data has shown that the stress levels of these high-risk pregnant women has gone markedly down. And in that time, homelessness has been prevented, domestic violence has been remediated, and women's personal safety has been secured. Food benefits have been obtained, and legal residency and citizenship has been established. So now we have partnerships, not just with the Division of Public Health, but with other state agencies, nonprofits, and healthcare systems. So on behalf of Classy, and particularly our medical legal partnership staff, led by Laura Graham and Megan Karasik, we're so grateful for the Division of Public Health's vision and commitment to health equity. And we thank you so much for this recognition, and most importantly, for your partnership over the last 8 years. And we hope well into the future, maybe justice will be found in the next 75 years. But if not, we'll be there 75 years later. I'm quite confident. Thank you so much.
Thank you so much, Dan. And really excited to see Shane Darby on the screen as well. So Shane, would you like to say a few words as well?
Yes, I want to say thank you guys for whoever nominated me for the Community Health Equity Dr. Kitty Exler Award. I really appreciate it. A lot of work is happening in the state, and I'm glad to just be a small piece of this movement to improving infant mortality rates, or just improving maternal care for our state, specifically for Black women. So for people who don't know me, my name is Shané Darby. I'm the founder and executive director for Black Mothers in Power, and it's focused on addressing Black maternal care in the state of Delaware. There are so many other Black women and other people, allies, who I can't even mention all of them now. So many. I'm just running the names through my head who have been a guidance to me, provided me with advice, have provided me with the support needed for me to be where I am right now with Black Mothers in Power. And I want to say thank you, like from Mimi, April Lyons, Tiffany Chalk, my whole board, Daisha, lovely Liz. I'm gonna hold up the award, y'all. It came in the mail yesterday. Kind of nice. It's like all glass. I never got an award like this. So I'm just excited for it. And thank you again. And I hope that next year we come here and we can celebrate that Delaware has improved their infant mortality rate here for all babies, but specifically closing that disparity gap. So I'm just happy to be here, and thank you guys.
Thank you so much for everything you are doing. We are so grateful to you, Shane, and to you, Dan, and your organization. And I'm going to hand it to the governor now to say a few words to close us out of this session.
Yeah, I just want to congratulate the award winners for their great work. I want to congratulate Dr. Rattay for this special award for tremendous leadership over this past year. And to all of those of you that are part of this coalition, the work that you're doing is so really incredibly important, as everybody has acknowledged. You have measurements, you measure your success, you measure your progress. I think that's really, really important. We should do that for everything that we do in government. This is one where you can measure it. But more importantly than that, think through the assumptions that we make about that explain, or that we think explain the conditions that are unacceptable to us. Maybe think beyond some of those assumptions we've made in the past, so that when we build it, they will come. And we will use the messaging to reach people that we know need our help. And finally, to deal with the systemic racism that pervades our society, and that really makes it difficult to address some of these longstanding problems. We're making progress, but we have a long way to go. So thank you to all of you for your great work.
Thank you so much, Governor Carney, and really grateful that you can join us. And from the bottom of my heart, thank you and Dr. Rattay for your leadership over the last year on behalf of the medical community and really all Delawareans. It's been an incredible year, and thank you, both of you, for working tirelessly. It's greatly appreciated. And thank you to Shané, or I'm sorry, congratulations to Shané and Dan for being incredible partners and your work alongside the DHMIC. It's now time for an innovation break. Please visit the innovation centers. You'll see on the left-hand side, watch the videos. You have a chance to ask questions of those organizations. And we will see you back promptly at 12:45 for the next keynote. Thank you. Thank you. Welcome back, everybody. Hope you had a chance to visit the innovation study and grab some lunch. Really happy about the next topic and speaker. But before we do that, I want to bring Melissa Minor Brown back, who is going to tell us about an exciting resolution in the state of Delaware.
Thank you, Dr. Paul. So we are celebrating Black Maternal Health Awareness Week. So it's only right to discuss the Black Maternal Health Week resolution that we presented on the floor in the House 2 weeks ago. It was House Concurrent Resolution 18. And this recognizes the week of April 11th through the 17th, 2021 as Black Maternal Health Awareness Week in Delaware. As we already know, and as we've heard throughout this entire summit today, that Black women in the United States suffer from life-threatening pregnancy complications twice as often as white women, and they die from pregnancy-related complications 4 times as often as white women. Also, our Delaware Black infant mortality rate is 2.9 times higher than the white infant mortality rate, and this number is actually higher than it was in 2018. So the gap continues to widen. And sadly, the state of Delaware ranks 14th in the nation for the highest prevalence of infant mortality. This Black maternal health epidemic has far too long gone recognized without intervention. And pregnancy within the Black community should not be known as a death sentence, not when many of the associated issues are preventable. I want to recognize the efforts of the Delaware Healthy Mother and Infant Consortium, the Delaware Perinatal Quality Collaborative, Shané Darby with Black Mothers in Power, Kingswood Community Center, and many other stakeholders. Work is now being done to promote various promising efforts, such as obstetrics hemorrhage initiative to reduce maternal and infant mortality, morbidity, and disparities, and improve public and professional awareness of the issues related to improving maternal health outcomes, women's experiences at childbirth, and critical postpartum care, especially for women of color. These groups also work to test small-scale innovative strategies to address the social determinants of health that are tied to maternal and child health outcomes through the Healthy Women, Healthy Baby Zones, and many grantee projects through grassroots community-based organizations that serve identified high-risk zip codes to address housing insecurity, access to doula support, community health workers, breastfeeding supports, healthy relationships for adolescents, because it goes that far back. academic and life skill supports, and job training education for women, along with additional initiatives to reduce stress and provide support to pregnant moms right here in our state. And this work that's being done deserves recognition. This is only the beginning. Like Governor Carney said, there's a lot of work that needs to be done, and we will continue this work towards closing the gaps on Black maternal mortality, along with our community partners who are dedicated to knocking down these barriers, shining a light on racial disparities, and creating a pathway for Black women and their babies to not only survive pregnancy and childbirth, but to be valued as the beautiful human beings that they are. Black Maternal Health Week is being recognized this week, April 11th through the 17th, and it comes at a perfect time because April is Minority Health Month. So I encourage everyone on this call to recognize that Black and Brown communities deserve quality, affordable, and culturally responsive healthcare, not only during the month of April, not just during a week in April, but every day of every year. Thank you.
And thank you, Melissa. Excuse me. Thank you for your ongoing leadership and work with the consortium. Greatly appreciated. Before we move on, I want to announce the winner of the next Healthy Women, Healthy Baby t-shirt, and that is Andrea Swan. So Andrea, congratulations. And we'll be getting that shirt out to you. Our next speaker is Dr. Edward Ehlinger, who is a public health metaphysician, probably the only public health metaphysician in the country. He spent his professional career working in various settings to advance equity and optimal health. He's integrated the values, practice, and approaches of medical care, public health, community building, and social justice, and is in his work as senior assistant surgeon with the National Health Service Corporation, director of maternal child health at the Minneapolis Health Department, director of and chief health officer at Boynton Health Services at the University of Minnesota, and commissioner of health at the Minnesota Department of Health. He's currently acting chair of the HSS Secretary's Advisory Committee on Infant Mortality. He's board certified in both internal medicine and pediatrics, and adjunct professor in the School of Public Health at the University of Minnesota. And as you can see, a musician. So Dr. Ehlinger, welcome, and so happy you could join us today.
David, thank you very much. I appreciate that introduction, and I really do appreciate being with the people from Delaware on this very important topic on this important date. Particularly when we acknowledge the work of Dr. Karyl Rattay, who has been a great colleague and a great leader. I got to work with her through my entire time as state health official. And I continue to work with her through ASTO on the Healthy Baby subcommittee of ASTO. She's just a great leader, a great colleague, and a great friend. And I appreciate being here on Healthy Mothers, Black Mothers Awareness Week during this month where we really focus on the minority health. And it's particularly important today here in Minnesota when we're struggling with the trial of George Floyd and the murder of Daunte Wright. Just 2 nights ago, our community is in a whole lots of feelings, sadness and anger and frustration. So it's a perfect setting actually to come to talk about some of the issues I'm going to be talking about and that have been talked about throughout the conference today. And it's also good to be here on the first day of Ramadan. With all my Muslim brothers and sisters here in the Twin Cities, which has really increased in number over the years, really celebrate Ramadan with them. A good time to reflect and pause and pray and really kind of think about where we're going together as a community. So with that in mind, let me get started on what I want to talk about, creating the conditions in which all people can be healthy. And one of the let me just get my shirt. There we go. Things that when I come to a community, either virtually or in person, I wonder, well, what was it why did they invite me? What do we have in common? What can I teach them? And so I said, well, how do Minnesota and Delaware compare? In size and population, Minnesota is much larger, both in size and in population. But maybe the words, where do I come from? And actually, we're kind of reciprocal. Minnesota comes from the Dakota word Mishota, which means cloudy or sky-tinted water, and that's the origin of the Mississippi River and Lake Itasca up in northern Minnesota. And you can see it is cloudy and sky-tinted. So the name of our state comes from a Dakota word. Whereas Delaware, it comes from Sir Thomas West, who was Lord Delaware, and actually the Native American, the American Indians were named after him. So just the reverse of what we have here in Minnesota. And I also want to take this time to acknowledge the fact that I'm here speaking from my house on land that was originally, or I'm not sure originally, many, many centuries ago was the land of the Dakota and the Ojibwe peoples. And so I acknowledge all of the things that they've done to nurture this land for generations and generations. So maybe we have educational institutions in common. Well, the University of Minnesota is much larger than the University of Delaware. I think maybe our mascots are similar in that we have these two little small things, a little gopher and a blue hen, not lions and tigers or bears. But we're different in size, and also our partners are large public institutions, except for Northwestern, which is the only private institution in the Big Ten. And we're horizontal in how we address how we focus with our partners across the country, whereas the University of Delaware, mid-sized school, and your vertical partners up and down the coast. And if we look at our state health rankings, Minnesota is one of the top 5. Well, we're number 7. You can see us there. And I pulled out, Minnesota and Delaware, which is number 30. We're surrounded by states that are worse than us in terms of the state health rankings. And you're surrounded by, except for Pennsylvania, by states that are better than you. So we're different in that. And I wonder about New Jersey. How did they get to be so good in that mix out there on the East Coast? But I do know we do have one thing in common, and that's this picture, the Washington crossing the Delaware. There were 3 original pictures of this Lotz picture. One was destroyed in World War II in Germany. One is in the Metropolitan Museum of Art. And one of these pictures, one of the most iconic pictures that we have in this country, is actually in the Minnesota Marine Art Museum in Winona, Minnesota, which is about 100 miles south of the Twin Cities along the Mississippi River. It's amazing, one of the treasures we have here in the state. But what do we have in common? Well, this is what we really do have in common. And this is what I hope we can learn from each other. It's about infant mortality, particularly the black-white infant mortality ratio. You can see Minnesota on the left. That's where we have the infant mortality of white infants, and we're really below the national average, or the Healthy People goals of white infant mortality rate in Minnesota of 4. And Delaware, it's 5.6. You're just above the Healthy People 2030 goals. But when you look on the picture on the right, the African American infant mortality rate, you can see that we have some real problems. We have huge disparities, both in Delaware and in Minnesota. And Minnesota, actually in this slide, looks a little bit better than it actually is, because we have about 50% of our births in Minnesota black births in Minnesota are to African-born women. So we have a lot of input from both East and West Africa here, and their births are healthier than the U.S.-born black women. If you look at just U.S.-born African-American women and their infants, the infant mortality rate is probably the highest in the country. It's like 14.3. And so therefore the disparities are huge in our state and also in Maryland. And I highlighted the Big Ten area when I talked about universities, because this is for a couple of reasons. One, I think we need to get academic institutions engaged in social determinants of health, particularly disparities related to mothers and babies. And some of the biggest disparities in the country are in this region that are covered by the Big Ten institutions. And so I've been arguing to get them involved with state health agencies to work on these issues for several years. And so this is something that we have in common. And this is what brings us together. And that's why I'm really pleased to be part of this and hearing all of these great presentations, and coming at the end of the day when you're all tired and you've been sitting on your butt for too long, you're listening to some great presentations by Kay Johnson, who I'm following her lead as the SACOM chair. Dr. Scott with that interesting study, the Sacred Birth Study, which truly is sacred. And then Dr. Kelly, who really talked to us about stories, and what an amazing presentation that was, sort of intimidating for those of us who have to come after that. But he really set the frame, reclaiming the narrative, building the narrative, starting with stories. And I think it's really interesting that today is the birthday of Eudora Welty, a storyteller, a writer from Mississippi, who said, long before I wrote stories, I listened for stories. Listening for them is something more acute than listening to them. When their elders sit and begin, children are just waiting and hoping for one to come out, like a mouse from its hole. And I think Dr. Kelly was pointing out the fact you have to listen for the stories so that we can reach out and connect to those stories. And so I think we have to think about, what is the story we should be looking for? What is the story that's going to bring us together? And for me, this is the story that got me engaged, particularly in maternal and child health disparities. This is a slide of the African American infant mortality rate on the top, the black line, and the white infant mortality rate on the red line. And 1980 is the beginning of the slide. And that is when I became director of maternal and child health for the city of Minneapolis, the Minneapolis Health Department. And previously I had gotten a lot of good medical training and a lot of great public health training, and had worked in clinical care in Montana with the National Service Corps. So I brought all of that good medical training and all that good public health training to the Minneapolis Health Department with the issue of addressing disparities in infant mortality, and put all the best medical care I could into practice in terms of getting insurance coverage, getting people on Medicaid, regionalizing perinatal care networks, improving newborn intensive care units, encouraging prenatal care. Did all of the good public health work in terms of home visiting and WIC and all of those things. And for 15 years worked on infant mortality reduction. So in 1995, I left to go to the University of Minnesota for 16 years and worked there with the upper end of the child health population at the University of Minnesota, and then was appointed Commissioner of Minnesota in 2011, which is the end of this slide. And so after that 31 years of being in Minnesota, working in public health, working on infant mortality, I said, let's look back and see what kind of progress we've made. And that's what really struck me at the time, and still strikes me, that after 31 years of all of the best medical care we could possibly provide, and Minnesota has the #1 healthcare system in the country. So it's not about medical care. We have great medical care. So despite all of the great medical care, and I think we have one of the best public health systems in the country, in Minnesota, we're ranked really high in that. But 31 years, all the best medical care and the best public health we could provide, the Black infant mortality rate in 2011 still had not reached the white infant mortality rate in 1980. 31 years, and we had not closed that gap. That told me that what we are doing is not working. And it's only gotten worse since that time. We continue to have those persistent disparities. And then I look at other things. It's not just in infant mortality. If you look at all of the indicators that we have, particularly education, this is one about reading scores. In this case, at 4th grade, 8th grade, and 12th grade, the students of color in 2008 still have not reached the level of their white peers from 1975. What we're doing is not working, and we have to change what we're doing. So I think this one of the stories of public health is from this quotation from Jeffrey Vickers, who said, "The landmarks of political, economic, and social history are the moments when some condition passed from the category of the given into the category of the intolerable." I believe that the history of public health might well be written as the record of successive redefinings of the unacceptable. So part of our story is putting out what should be intolerable, but what is given, identifying what we take as given. We just assume that Black women are going to die at 2 to 3 times the rate of white women. Why is that a given? It should be intolerable. The same thing with African American and American Indian babies dying at 2, 3, 4 times those of their white peers. It's just a given. Or the fact that African-American males, teenagers, adolescents are going to be imprisoned at 10 times the rate of their white peers. Given the fact that we have spending the most money of anybody in the world on healthcare, and yet we have these huge disparities, that should be intolerable. So what we in public health need to do is redefine the unacceptable as part of our storytelling. And also, we need to be listening for stories. And I think Dr. Kelly pointed this out really well, from other sources beyond our usual places of getting information. And I like this quotation from William Carlos Williams, who was a physician in New Jersey, right next door to you. He said, "It's difficult to get the news from poems, yet men die every day for lack of what is found there." And so I think we really need to be looking for other ways to get the stories. And that's why I really appreciate the Delaware Poet Laureates. When they were appointed by Governor Markell at the time, he said that their poetry for them is far more than rhyming words. It's salvation of the streets. It's actually improving the health of mothers and babies and people of color and everybody in the state with the stories. So I think and I hope you guys get Al Mills and Ekdambi Chukwuocha to come to your conference at some point and share their stories, because they have powerful words. They write, "I write for the youth. I write for the youth ain't never been looked up at the clouds. I write to explain the pain or put happiness in words. I write to give voice to all the beautiful everyday things, for the cycle of poverty, for all the family trees that died when grandparents died, for all the togetherness that was displayed when the grandparents lived. See, my words is my work. My work is my words. This ain't a poem. It's my life. It's why I write." In that short poem, the pieces that I grabbed out of the poem, they highlight the fact of connections, of history, of poverty, of beauty, all of the things that we really have to be concerned about in addressing communities and people in those communities. But you may ask, well, why should we be listening for equity? Why is it important? Why should we care? And I'll be really crass. You've heard some numbers, and I was appreciative that you didn't get as many numbers during this conference as are in many conferences. So you oftentimes get overwhelmed, but it is a numbers problem. We're becoming an increasingly diverse society, and pretty soon we're not going to have any majority race in this country in 2050. And so if we have the disparities that continue and we become increasingly diverse, it's a math problem. Our overall average is going to go down. Our overall quality is going to go down. So basically, it's a math problem. But in reality, it's a social justice problem. And that's what public health is about. Bill Foege, who was the CDC director, said, "The philosophy behind science is to discover truth. The philosophy behind medicine is to use that truth for the benefit of your patient. And the philosophy behind public health is social justice." And to me, social justice means that everybody gets their basic needs met. Everybody has the opportunity to thrive, and nobody benefits at the expense of somebody else. And in our country, all three of those things are not being achieved. Not everybody is getting their basic needs met. Not everybody has the opportunity to thrive, and some people are benefiting at the expense of others. And we should, and one of the points I make is that we have vested interests in the outcomes. That's why we should pay attention to it. But I came across this quotation from somebody born in Delaware, the Marianne Shade, who was the first Black woman publisher in North America and the first woman publisher in Canada. She said, "Were it not for the monster of slavery, we would have a common destiny here in the land of our birth." As the Langston Hughes poem that was quoted, "It ain't America for me." And that's what I think we have to do. We are vested in it. We do have connections, and we have to make this a truism that we all have vested interests. And it comes, these quote pointed out, Michael Harrington, who wrote The Other America, which really stimulated John Kennedy and Lyndon Johnson to set out the war on poverty, said, "One cannot raise the bottom of society without benefiting everyone above. We all do better when we all do better," as my Senator Paul Wellstone said before he died. And Dr. Martin Luther King Jr. said, "We may all have come on different ships, but we're in the same boat now." We have connections, and I'll show you how we are connected. He said, "Injustice anywhere is a threat to justice everywhere. Whatever affects one directly affects all indirectly." And this is how it plays out. On the left, we have the infant mortality rates. The red and the green and the blue are the infant mortality rates of all races in blue, the whites and the green and the blacks and the red, going from upper left to lower right, going in the direction that we want, but not as fast as we want. The line going from the lower left to the upper right is the disparity in black-white, the ratio. You can see that went down during the 40s, actually when we were in World War II, when we all had a common interest. We were all feeling like we were working on a common goal. And for the first time in our history, and the only time in our history, we provided universal access to maternity and child health care to all service members. So they had access to care, and we worked collectively. Everybody felt a sense of belonging. Disparities went down. Then after the war, it went up, and it dropped again during the war on poverty, when we again had this focus on community, on reducing disparities, on having access to care, and dealing with the social determinants of health. And then, but when that got kind of undercut because of the power of the war on poverty, and our disparities started to go up, and they've continued to go up and maintain a high level since that time. And on the right, you can see the infant mortality rate in the United States compared to the Organization of Economic Community and Development, Cooperation and Development, the OECD countries, the other high-income countries. And we were tracking with those other countries until about 1980, when we started to diverge from them and become worse. In 1960, our infant mortality rate was 12th best in the world. We're now at 38th or 40th in terms of infant mortality. And it started to get worse. Our overall rate started to get worse when our disparities started to increase. So disparities are linked to our overall improvement in health. And on the opposite end of the spectrum, you can see on the left life expectancy by race, and you can see again a plateauing of improvements in the 1980s. Again, you'll see a little bit later when we started to put more money into medical care and not into public health, we had a slowing of the improvement in the Black longevity race. And it's at that time, this slide on the right, which shows how we again started to fall behind other countries in the world, other high-income countries in the world, in life expectancy. So as our disparities increased, we fell behind competitively with other countries in the world. And certainly in the last year with COVID, taking a much greater toll on populations of color and in the indigenous community, that our overall decline in life expectancy has about been 1.13%. But most of that decline is in the communities of color, whereas white men and white women have lost less than a year in terms of life expectancy. For Black men, it's 3 years. Latinx men, 2.5 years. Black women, 2.3 years. So it's going to get worse. These disparities are going to get worse, and our overall longevity compared to other countries is also going to decline. I don't have a similar kind of comparison rate for maternal mortality, but this is a slide that certainly should be shocking to all of us. When I got into maternal and child health, we thought, the rates of maternal deaths were very, very low. But since that time, they've increased dramatically, particularly among women of color. And this is one of the things that should be totally unacceptable, because most of these are preventable. And that's why we need to have conferences like this. The last reason why I think we should care about equity is that I think equity and social justice are existential issues. Like nuclear war, like climate change, and like the pandemic we're going through, inequities challenge us, challenge our society in ways that affect all of us. And if we don't deal with them, our society is going to change in ways that we may not like it. The good news is that how you address inequities are also the ways that you address pandemics and climate change and nuclear war, by building relationships, by looking at a broader definition of health, by focusing on cooperation, by focusing on prevention, by focusing on the needs of everyone, and getting rid of the competition of trying to do better than other people. We want everybody to be healthy. As Paul Wilson said, we all do better when we all do better. But it is an existential threat. Frederick Douglass pointed this out, 150 years ago, where justice is denied, where poverty is enforced, where ignorance prevails, and where any one class is made to feel that society is an organized conspiracy to oppress rob and degrade them, neither persons nor property will be safe. We are feeling this immediately in Minnesota. We felt it in May when George Floyd was murdered. We're feeling it the last couple of nights when Daunte Wright was killed. It's a tinderbox here. It is, the National Guard is out. The police are mobilized. Communities are frightened. There's just fear in the air. Changing the society, we need to deal with these disparities. Alexis de Tocqueville said, permanent inequality of conditions will be the death of democracy. And that's why democracy building requires that we deal with those disparities. But so how have we gotten to this point where we have such great disparities and inequities? Because I think we've listened to the wrong stories. The stories that have been created come about because of this worldview. Bootstraps individualism, virtue of work. If you just work hard, you can do well. And that free market is the way to go. We're going to solve all of our problems with free market solutions. And education, it's for job training. And structural discrimination, that's a thing of the past. We got rid of that in 1960. We had the Civil War, that got rid of it, the 13th, 14th, 15th Amendment. And then we had the Civil Rights Act of 64. That's a thing of the past. We rely a lot on technology and specialization, a growing mistrust of science. They don't know what, I don't trust on those things. That vaccine hesitancy is all part of that. And that government is the problem, not the solution. So we need small government. And what that has done is led to a decreased investment in the commons and a decrease invested in people who are disadvantaged for whatever reason. Because if they just worked hard enough, they would do well. And so we're not investing in things that everybody benefits from. It's increased competition and polarization and has led to this dominant health narrative, that health is an individual responsibility, that competition and consumer choice are the ways that we need to go, that healthcare should be run like a business, that structural discrimination is a thing of the past. Therefore, anyone can choose to be healthy. And that medical care will cure me if I get sick. And I know what's best for my family. Don't let the government tell me anything about what I need to do. And health is a private matter. And what that has done is that it has led to blaming individuals and has led to an overinvestment in the biomedical model. It focuses that idea of you just have good medical care and people do the right thing with their behaviors, we will be fine. So let's just focus on blaming individuals for the bad things that they do and invest in the biomedical world. And that investment in the biomedical world gets us here. We were doing along the x-axis is how much we spend per person per year on health care. It's now really over $13,000 per year in the United States. Along the y-axis is the life expectancy. And in the red line is the United States, the gray lines are all the other OECD countries. And as you can see, we were tracking with the rest of the world up until about 1980. And then we started to spend more and more money on medical care. And at that same time, our life expectancy started to fall behind, improvements in life expectancy started to fall behind those of the other countries. It's almost as if the more money we put into health care, the less healthy we become. I think this is where one of the things that, because I think part of the reason is it's not because the money is going to places where it doesn't make the biggest impact. For example, in the OECD countries, for every dollar spent on healthcare, about $2 is spent on public health and social services. In the United States, for every dollar spent on healthcare, only about 55 cents is spent on public health and social services. And those public health and social services are the places where health can really be created. So you can see in the chart that the United States doesn't spend more than a lot of other countries in terms of total health and human services dollars, but they spend a lot more, way over 50% on the medical care at the expense of public health and social service. And I've been around in public health for a long time to see the impact of that. When public health funding was cut in 1981, immediately we had people on the streets, immediately being homeless. We had people in food shelves. We had people who lost their health care. We had an increase in disparities in maternal and infant health outcomes. So that's the other part of, so I talked about the other part of the story about public health is identifying what's unacceptable. The other part of the story is that we need to identify what we need to do. And public health is what we as a society do collectively to assure the conditions in which people can be healthy. We need to assure those conditions. That's what we need to do. And so we know that it's the living conditions that actually make the biggest difference in health. You know, I'm fortunate, I live in a community of opportunity. I'm in my house, I've got decent internet connections, I hope. You know, I can walk to the grocery store. I have walking and biking paths that are close. And when I call the police, they will come and they'll treat me with respect. So it's easy, relatively easy for me to make good health choices. On the other hand, just a couple miles from here, where George Floyd was murdered, 10 miles from here, where Daunte Wright was killed, we have lower opportunity communities where they have a lot of rental housing and fast food restaurants and not in unsafe neighborhoods and payday lenders. And when they call the police, if they come, they're unlikely to be treated with respect. So it's difficult for them to make healthy choices because the healthy choice isn't even a possible choice in many cases. And you know, this is just a slide of Philadelphia. You know, just within 10 miles, there's 20 years of life expectancy difference. And those places where we live, how the living conditions are really impacted by public policies, not by the choices made by the individuals. These are policies that related to the GI Bill or redlining and market forces and all of those kinds of things that have really impacted housing. This is not about personal choice. This is about public policies. And we had talked about, you know, redlining with obstetric care, and there's still redlining that continues today, or redlining, which is really white supremacy. If you look at on the left, this is the Chicago area. If you can see on the left, the red line is where the cases of COVID-19 are the highest. In the middle, in the green, is where the number of Paycheck Protection Program loans are. That's in the green. And the blue is where the number of COVID vaccine doses are given. You can see the COVID cases also reflect where the people of color are. And so there is still redlining going on where the money and the vaccines are going to the white population. This is white supremacy, well defined. So we spend a lot of time and have over the last 10 years on the diseases of disconnection and despair, anxiety, PTSD, depression, and alcohol use, substance abuse, addictions. A lot of money goes into that. And we recognize, that we have to do that, but we don't recognize always that we have to go a little bit further down on this tree. Yes, we have identified adverse childhood experiences, recognizing that divorce and drug use and alcohol abuse and mental illness impacts children, but we also know increasingly that it's adverse societal conditions, bad schools, income inequality, unemployment, historical trauma, poor access to all kinds of health and human services, redlining. That's where we really need to go if we're going to have this tree branch in this springtime and have leaves that benefit and shade everybody else. So how do we change living conditions? We're not taught how to do that. We really need to build the Capacity Act. We need to build the power. So when I was state health commissioner, we really looked at the organizing strategy about organizing the narrative, organizing the resources, and organizing the people as a theory of change to really address disparities. Organize the narrative, build the public understanding and public will. Organize the resources so we can have them structured in a way that can actually change our systems, and organize the people so they can impact decision makers. And so we took that theory of change and put them into what we're calling the triple aim of health equity. Expand our understanding about what creates health, changing the narrative, implementing a health in all policies with health equity as the goal, organize the resources, and strengthen the capacity of communities to create their own healthy future. That's organizing the people all around the whole idea of social cohesion and social justice. And that's where I use this to really work on our state health department, and also worked with ASTO when I was ASTO president on socializing this idea of the triple aim of health equity as a way, the simple tools to really change how we change the inequities in our society. So I'm going to go through those briefly. Basically, expanding the understanding of what creates health. The the common mantra is that clinical care is really important and that healthy behaviors are important. Well, clinical care really is only about 10 or 20%, as you're now probably aware, and health behavior is about 30%. It's the social and economic factors, 40%, all of the vital conditions or the social determinants that the World Health Organization has identified. Those are the factors. And so some of those factors, some of the social conditions and factors, segregation, lack of high school graduation, low social support, these are the number of deaths each year, more than, about equal the number of deaths or even more than the deaths of what's just happened with COVID-19. These are factors that are causing people to die, particularly people of color and American Indians in our society on a yearly basis. And so those conditions, so do behaviors really determine 30%? Is the healthy choice a possible choice? So if you look at the communities of opportunity and the fact that we have a lot of adverse societal conditions, and each year we spend billions of dollars marketing bad products, particularly to people of color, I question whether or not the behaviors really are 30%. It's almost like this slide, the real reason the dinosaurs became extinct. Let's blame them for smoking, ignoring the meteor that hit or the climate change that occurred. It was their individual behavior. So given all of those factors, I believe that it's the socioeconomic factors are probably 60 or more % of what really determines health. Now, I don't have data to support this. This is just the way from my experience of looking at what has happened over the last 40 to 50 years. And it's those conditions, those socioeconomic factors that are really shaped by money, power, and social policies that are beyond the control of the individual. Social determinants of health are things that affect your health that are beyond your individual control. And those things are really controlled by public policy. And they disproportionately affect Black, Brown, and Indigenous communities. And we have to acknowledge that structural racism is at the core of that. I made that statement in 2014 when I was state health commissioner in our Advancing Health Equity report to the legislature. And and talk about all of us having a role to play, we were told earlier, don't complain about your privilege. I was privileged to be health commissioner, and being a straight, white, male physician, to say in a public agency that structural racism is at the core of the problems in our state had a big impact. I could say things that had a different impact that if somebody from another race had said, it would have had a different impact. And by saying that, it actually changed the conversation in our state. It opened up conversations for the communities of color saying, thank you for saying what we already know. And now we're going to hold you accountable for that statement. What are you going to do to make a difference? So we told the story, told the truth, and then had to be held accountable to that. So we have to change the narrative. As Lincoln said, public sentiment or narrative is everything. With public sentiment, nothing can fail. Without it, nothing can succeed. And the stories that we tell help change that narrative. So we have to change the narrative from the one that I had identified earlier, the dominant narrative, to an alternative worldview of interdependence, social cohesion, virtue of work, but a different kind of definition of work. Volunteering is work, parenting is work, caring for elders is work. All of those things, and even though they don't get paid, they're important work. My mentoring, coaching, all of those factors. Social responsibility, social justice are necessary. Education is for enlightenment. Equity is a challenge of the present. We need generalists, we need cooperation, and we need government, appropriate government. And then that'll lead to an alternative health narrative about health as a community collective responsibility, that health is a right, a community good, that well-being, not economic success, is the goal of our healthcare system, that equity is a challenge and we have to deal with historical trauma. We need to balance our investment in public health and medical care. We need a health in all policies, and government needs to be there to protect folks. So we need to, secondly, then, to implement a health in all policies, organize the resources. We know all factors. Health is not just about medical care and public health care or the public health systems. It's every system that's identified on this chart. And so when I was health commissioner, I really went with all the other commissioners and all the other agencies and asked them about their input on public health, impact on health. And after some conversation, they realized they all had an impact. So we all worked collectively on these factors in red on the outside, on a minimum wage. You know, I complimented our governor in the fact that his greatest public health achievement during his term in office was increasing the minimum wage in Minnesota. Because if you can increase the minimum wage to get people above the lowest quintile of income, you can increase their life expectancy by 3.5 years. Or paid leave. 10 weeks of paid maternity leave will decrease infant mortality by 10%. So we worked on all of these factors. They are not necessarily in the swim lane of the public health agency, but they're certainly in the pool in which we are all swimming. And so those are issues that we all have to work on. And I think probably the best health in all policies approach was the war on poverty in the 1965 to 67 Congress. Look at all of the things that got passed by that Congress. Head Start, Title V, Medicare, Medicaid, school lunch, highway beautification, air pollution. I mean, a whole range of, this is health in all policies. And they focused on the community. And when they did this, the disparities went down in infant mortality, which you can see in that slide in the middle. And this is the opportunity we have with the Rescue Act that was just passed. It can be of the similar magnitude as this if we do the work. So take all of those recommendations that Kay Johnson gave to you and work on those, because that will actually have an impact that will be tremendous. So we have an opportunity that we have not had for 60 years. And then leading into the community, building community capacity with the health in all policies, my view is that the greatest public health achievement of the 20th century was giving women the right to vote, the 19th Amendment. And you can see that passed in 1920. And look at the maternal mortality rate on the slide on the left. It dropped dramatically after 1920 because many of the programs, particularly the Shepherd-Towner Act, which led to the Title V Act of the Social Security Act, home visiting, data collection in state health departments, all came about because women got the right to vote. It had an impact on maternal mortality and on infant mortality. But you can also see on the infant mortality one, there's also a little blip in 1965 where it started to go down again. Again, when Voting Rights Act was passed, infant mortality started to decline. And I just have to point out the fact that I was born in Wisconsin, so I'm proud that Wisconsin was one of the first states to ratify the 19th Amendment. Minnesota, where I live, ratified it as soon as they came into session. Delaware rejected the 19th Amendment and didn't ratify it until 1923. And you can see the partners that Delaware had with the states that ratified. Connecticut, Vermont, and Florida just never voted. And I always learn something when I give these talks, because I didn't realize Delaware had been the first state to ratify the U.S. Constitution, and that you actually voted against the 14th Amendment and didn't ratify 13th, 14th, 15th Amendments until 1901. History tells us a lot, and so I think we have to learn from that. So, but that all leads into the third piece of the triple aim of health equity, strengthening the capacity of communities to create their own healthy future. You know, we focus a lot on people with complicated issues on the far right, want to keep them from dying. We then try to keep people who are afflicted with something from getting sick from that, and then we have vulnerable populations. And this is where we put most of our effort, specialty care in hospitals to keep people from dying. That's where our tertiary prevention is. Primary care does all of the screening things to keep people from developing complications. And traditional public health is the primary prevention, keeping vulnerable people from getting something that eventually will cause them problems. And we spend less and less money as we go from the right to the left. And this is where I think, as I said, we put most of our efforts. But the problem is the vulnerable population is increasing and overwhelming our charity care system, our medical care system. So we really need to even move further to the left to safer, healthier populations, to actually keeping people from becoming vulnerable. And this is where social justice works. This is where we work on living conditions. We work on building democracy by really building accountability, developing leadership, getting rid of the whole idea of deprivation and dependency and violence, but really focusing on connections and democracy. And then focusing on community. So the community is the fullest sense in the fullest sense, is the smallest unit of health, as Wendell Berry says. To speak of the health of an isolated individual is a contradiction in terms. Health is in relationships. It is not about individuals. That's why I argue that we should not have patient-centered care. We actually should have community-centered care. And that gets into the core of the triple aim of health equity: social cohesion and social justice. Mother Teresa said, the greatest epidemic today is not TB or HIV or leprosy. It's being unwanted. Being unwanted, unloved, uncared for, forgotten by everyone is a much greater hunger, much greater poverty than the person who has nothing to eat. And so we really need to focus on social cohesion and social justice. And that's a sense of belonging. If you don't have a sense of belonging, we're not going to be able to really improve our health, improve our communities. We're seeing that play out right now, in Minnesota, where people don't have a sense that they belong. They don't feel safe. They don't feel connected. They don't feel that their voices matter. And it is destroying it has the potential to destroy our community. A proper community, as Wendell Berry says, is a commonwealth. It answers the needs, practical as well as social and spiritual, of its members, among them the need to need one another. Health is about belonging. So if you ask all of the right questions, you can advance health equity. And I'll put these, my slides will be available, and you can, talk about what values underlie decision making. What is the health implications of a policy? Who's at the decision making table? Our relationships being developed. All of these are questions that you need to ask if you're looking at any policy or program. And, what would it look like if equity was at the starting point for all of our decision making? Our work would be different. Our work would be to implement the triple aim of health equity. We would work on changing the narrative. We would implement a health in all policies approach. We would strengthen the capacity of communities to create their own healthy future, all with the idea of social cohesion and social justice at the core. So I'd mentioned earlier that William Carlos Williams said, it's difficult to get the news from poems, yet men die every day for lack of what is found there. And I recognize that I'm getting a little bit close to the end of my time, and maybe even over, but I'm going to take the prerogative of following up on what William Carlos Williams said, that we need to do things that related to poetry. So Langston Hughes, you heard his name earlier. He wrote A Dream Deferred, which inspired Martin Luther King Jr. and his I Had a Dream speech. He said, what happens to a dream deferred? Does it dry up like a raisin in the sun, or fester like a sore and then run? Does it stink like rotten meat, or crust and sugar over like syrupy sweet? Maybe it just sags like a heavy load, or does it explode? What happens to a dream deferred? And your poets laureate here in Delaware said, in this, they wrote, I had a dream that I was in America. I was actually in the land of the beautiful and the home of the brave. And all these strangers turned to me and said, what are you doing here? Don't you know dreams are illegal in the ghetto? Without dreams, you are equivalent to being non-existent. Our children need to be told they can achieve, and that God bless those that hold on to their dreams. We have to take down the signs so that our children won't know that the devil is trying to make dreams illegal. We have to hold on to our dreams. So, given the fact that I think the most powerful part of the inauguration was Amanda Gorman's poem, history has its eyes on us. So we lift our gazes not to what stands between us, but what stands before us. And knowing that we have to develop a movement for social justice. And I think every movement has to have a soundtrack. So I'm going to give you a couple of songs that can be part of our soundtrack. We can't defer our dreams or be deterred by others' schemes. Keep our eyes on the prize, hold on. We must embrace our dream with health equity as a theme. Keep your eyes on the prize, hold on. Hold on, hold on. Keep your eyes on the prize, hold on. And you'll recognize that you don't need to be a good musician, and you don't have to have a good voice, which I'm telling you I don't have, to actually be part of the movement and get part of the soundtrack. We must all take a stand when there's inequity in our land. Keep your eyes on the prize, hold on. Social justice is our goal for the community as a whole. Keep your eyes on the prize. Hold on. Hold on. Hold on. Keep your eyes on the prize. Hold on. From history, we all know we can't accept the status quo. Keep your eyes on the prize. Hold on. That's why we're here today, to help find a better way. Keep your eyes on the prize. Hold on. Hold on. Hold on. Keep your eyes on the prize. Hold on. And when Dr. Kelly talked about call and response, so I just added, that's one of the nice things about PowerPoint. You can add things as you go. And so this is a call and response song, which I hadn't planned on doing, but he convinced me to do it. Put one foot in front of the other and lead with love. Put one foot in front of the other and lead with love. Lift up your eyes, don't you despair. Look up ahead, a path is there. Put one foot in front of the other and lead with love. Put one foot in front of the other and lead with love. Keep your eyes on the prize is an old song. This is one by Melanie DeMore, a current singer, and we have to put forth a lot of her work. Don't give up hope. We're not alone. Don't you give up. Keep moving on. Put one foot in front of the other and lead with love. Put one foot in front of the other and lead with love. To give us hope for humanity, let's build the world of equity. Put one foot in front of the other and lead with love. Put one foot in front of the other and lead with love. So I focused a lot on dreams, the dreams that Al Mills and Nyambi Chakuocha talked about. Without dreams, you are equivalent to being non-existent. Our children need to be told they can achieve, and that God bless those that hold on to their dreams. And William Butler Yeats said, in dreams begins responsibility. I hope you all have dreams. I hope you all have dreams of a better world for yourselves, for your kids, your grandkids, your great-grandkids, and for the 7th generation. And those dreams if you could dream it, you have some responsibility to make it true. And that's why I'll end with the song from South Africa. Bambalela, bambalela, oh bambalela, bambalela, bamba, 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 oh bamba, bambalela. It means never give up, oh never give up, never give up. Never, 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 oh, never, never give up. Bambalela, bambalela, oh, bambalela, bambalela, bamba, 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 oh, bamba, bambalela. Nurture your dreams, oh, nurture your dreams, nurture your dreams. Always, 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 always nurture your dreams. Gwendolyn Brooks, the first African-American woman to receive the Pulitzer Prize, says, live not for the battles won, live not for the end of the song, live in the along. This work has to continue forever. We can't just look for the end. Yes, we can have a goal, but we know we will continually describe what's unacceptable, so we have to live in the along. Live in the along, oh, live in the along, live in the along. Always, 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 always live in the along. Bambalela, bambalela, oh, bambalela, bambalela, bamba, 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 oh, bamba, bambalela. The field is very important. The work is incessant, so we have to continue on. Never give up, oh, never give up, never give up. Always, never, 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 oh, never, never give up. Bambalela, bambalela, oh, bambalela, bambalela, bamba, 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 oh, bamba, bambalela. Thank you very much. Sorry to take so long, but I hope it was worth it.
Ed, thank you from one musician to another. I'm glad you did the singing and I didn't have to, because that was really wonderful. Maybe you can show people your guitar that you showed us last night.
Oh, so Pete Seeger, one of my heroes, had a banjo, and on the banjo sounding board, it had a thing that said, "This banjo kills fascists," and that seemed kind of violent. So I had somebody make a guitar that put health and equity on the sound on the keyboard, and then social justice on the sounding board.
Thank you. I said I wanted to be the Sonny Kelly of neonatology. You are the Woody Guthrie of public health. So, thank you. We have time for one question before we move on, and I believe the question is, can you recognize or identify one policy that would create health for both mom and baby?
Well, I mean, this is a question we get frequently. What is the one thing? And everything is necessary. I mean, it's all connected. So that if you're working in the field of education, the policies that'll help the moms and the babies will be one thing. If you're working in the field of public health, moms and babies, if you're working in transportation, there'll be things that, so each of those areas have to do it. The best thing to do is what you have an opportunity to deal with. Some of the things that Kay Johnson identified, paid leave. Let's work on paid leave. That'll help both moms and babies. Let's look at the earned income tax credit. That will help moms and babies. Let's work on minimum wage. I mean, all of those things. It's really not about medical care. It is really about the social conditions. So choose one of those things. If you have an opportunity, if you can make a change in it, if you have an opportunity, that's the one you should focus on. Go for the opportunity.
Thank you. So on behalf of the entire Delaware Healthy Mother Infant Consortium and the state of Delaware, I just want to thank you for joining us today, bringing your guitar, bringing your joy, and it was great interacting with you and learning from you. So thank you. And with that, I have let me, before I move on, announce one last prize winner, and that would be Ariras Torres. Ariras, congratulations on winning the last Healthy Women, Healthy Mother Baby t-shirt. Okay, Tiffany and Susan, you're on before I start. Go ahead.
We can't hear you, Sue.
Thanks, Tiff. On behalf of the DHMIC, Ed has us clapping. We're all texting each other. Ed, that was an awesome way to close. Thank you so much for being our finale. And thank you to all of our speakers on behalf of the planning committee. We want to thank you for kicking us off, Kay, with such a strong start. Sonny, with unbelievable power of story, followed by the launching of our premiere video, which we're so excited about. And then Dr. Karen Scott, and having the governor, Dr. Rattay, being acknowledged. And then having Ed wrap it up. I mean, wow, what a closing. So part of the pleasure of being chair of the summit is really interacting with these speakers throughout this season. And it's been a pleasure to each one of them. They were scheduled, 3 of the 4 of them, for last year. They hung on and they came back to be with all of you virtually. So we just give them a round of applause, because it's so wonderful to have them all with us today. The other thing is, we really want a shout out to all of you who registered. There was over 450 who registered today to be part of this summit. This is a great day for many of us. David, Tiffany, and I, we all look forward to this day, as well as many others in our team. And we miss being with you in person, as David shared earlier. But we're really happy that this many of you joined us today and that you hung in there with us for this full schedule. This program is only as good as those of you who attend and those of you who participate. And we have a special shout out, and we'll talk more about that. The virtual innovation stations, we had 12 stations and over 32 different community partners represented. We know this took time and commitment from each of you. And we know we had a full schedule, but we really thank each of you. And Tiff will go and share more information about that in a moment. The other thing is that I really need to thank the team. It's a fun thing to be chair of this group, but there's an amazing group behind me. Tiffany and other people not on this screen from Public Health, Leah Woodall, Mawuna Gardesi, our DHMIC consultant, April Lyons, and then the ABC team, who is very robust. Jen Buckman has been our right hand, Chrissy, Alex, Joanna, Chris, Stuart. Chris is the function behind everything today. We really thank you, and it's been a pleasure to work with each and every one of you. As we said, today is a fun day. We're not over yet. David will, you're all hanging on for the closing, we know with David, which is a favorite part of many of you. But we're really empowered by the words of our speakers, by the many comments that you have posted, the many positive comments that you've posted in the chat. They mean a lot to us, and those are things that are also comment to help us to do better and to be better as we move forward. I'll turn it to Tiff, and then I'll get the final word before sending it back to David. Tiff?
Thank you so much, Susan. Thank you again. I concur with all the thank yous that Susan had. It is a true labor of love to be on the planning committee for the summit, but looking at the fruits of our labor is just wonderful as we end the day today. So I just want to remind everybody that our virtual innovation stations are full of wonderful resources and information from the organizations in there, and those stations will be open even when the summit closes. So you can stop back in, check out some of the videos, look at some of the presentations. They really put together some great presentations for you all. And also to let you know that this information, this hub will be available for you with all the content for at least the next year. So you can take your notes, come back, revisit 6 months from now, and if something sparks in your head, you can come back and we'll have all the information here for you as well. So I would be remiss if I did not acknowledge again that it is Black Maternal Health Week this week, and we are so excited that we were able to host our summit during this week. And I wanted to give a nice plug for our next event that we are having on this coming Saturday. It's a virtual event where we will launch part 2 of our Her Story Black Maternal Health video series, and we'll have a panel discussion with our wonderful representative Melissa Minor Brown and Dr. Marshalla Lee, and we also will have some consumers who will be a part of the panel for our event on Saturday. It's at 10 a.m. It's a 1-hour event, 10 a.m. to 11 a.m. And you can register. It's a free event as well at our website, www.dethrives.com. And also the information is in the resources tab in this platform as well. Now back to you, David.
Okay, one more thing.
Go ahead, Susan.
One more thing. We want to thank the virtual artist. Some of those, you've seen some of those in between our breaks on the screen. All of her interpretation artistically through drawings and through her word imagery will be available to each of the participants. In addition to the other things, thank you, that we had available for you. You've written in the chat, and we've told you, as Tip said, that all of the speakers' recordings will be available and all of the notes. So we really appreciate this. And yes, please go visit the innovation stations. And the last thing that Tiffany mentioned, our video that's going to be launched part 2 this Saturday, Her Story. And we love the title. It's Her Story, Claiming Our Power and Resilience. And I leave you on that note because it was a love project for Tiffany, and we support her in this. And this day is a passion project for many of us. So thank you once again to my committee and for each of you for attending. David, thank you.
Thank you to both of you. All right, I'm going to attempt to share my screen here. Okay. So this is a tough job to sum up at the end of the day. And but much like Susan and Tiffany, I want to thank everybody who planned this committee. They did the hard work for me. And many of you recognize and remember Dr. Esther Lee, who led the way for many of us. And we stand on her shoulders. And Shané, if you're still with us, that's who your award was named after, a great mentor for many of us. And so in summing up, our last 15 years in the day, in thinking about things, I think we've had a lot of successes, and obviously we have a lot of opportunity moving forward. And I hate to go back to data, But I did learn from Sonny, so I want to let the data tell a story. And so the data here are the details in the story. And here's where we stand for infant mortality from 2000 to 2019. And on the y-axis here are infant mortality rate, and that's deaths per 1,000 live births. And on the x-axis is time. And the blue bars here are Delaware's infant mortality rates, and the black bars are the United States rates. And you can see that we started our work in 2004, 2005. And since then, our infant mortality rate has been reduced 22.5%, which is really great. That's the good news. The United States rate's gone down about 6% during that time. So good news, we've really reduced our infant mortality rate. The bad news is we still have a ways to go to narrow that gap. And then when I think about the drama in the story, as was mentioned time and time again, it's the disparities. And here's what disparities look like in Delaware for the period 2015 to 2019 with infant mortality. And again, infant mortality is on the y-axis. And we can see the Black non-Hispanic infant mortality rate in Delaware is 12.3. The white rate is 4.3 per 1,000 live births, and the Hispanic rate is 8. And if you look at the disparity ratio up on the upper right-hand corner, the Black to white disparity ratio is now 2.9. And so despite our successes, that disparity ratio is going up, much like the graph that Ed showed you in the country over time. The Black rate has gone down, but at a slower rate than the white rate. And you can see that the Hispanic to white disparity ratio is 1.9, and that's about the same as it's been over the last 15 years. So this is the drama. This is the work. This is the one slide where we have work. I'm often asked about rates by county, and here's what it looks like over the last reporting period from 2015 to 2019. And we can see here once again on the y-axis is infant mortality rate, and the x-axis is by county. The non-Hispanic white rate are in the lighter shaded bars. The Hispanic rate is in the blue bars, and the Black rate is in the black bars here. And you can see that it's not only race, but it's place. There's this race-place interaction in the state of Delaware, where by far the highest infant mortality rate are the babies born to Black mothers in the city of Wilmington. And the lowest rate is babies born to white mothers in Kent County. And you can see that's quite disparate there, with a rate of 3.3 for white babies in Kent County and 18.2 for Black babies in the city of Wilmington. And so in a nutshell, this is our problem. This is what we have to really tackle in the years coming forward, despite our successes. And you can see here, again, it's beyond race. It's why is the city of Wilmington so different, even for Black babies or white babies, than the rest of the state? Many different factors here. The real driving factor for infant mortality is premature birth. And this is the rate of premature birth. On the y-axis here, the percent of premature births, that's considered any baby born prior to 37 weeks gestation. On the x-axis is time. The black bars here are Delaware. The blue bars are the United States average. And, again, I think there's some good news here. If you look back to 2004 and 2005, when we started our programs, that gap was pretty wide. And if you look over more recent years, there have even been some years where our premature birth rate is below the United States average. But overall, that gap is narrowed greatly over the last few years. So some real success in reducing premature births as well. And I think we contribute some of those successes to the great work of our programs. I mentioned the continued drop of infant mortality. Really proud of that work. Our mini grants that we've given out over the last few years are really aimed at attacking the social determinants of health at the community level and listening to the community, listening to those stories, and listening to what the community needs and providing those services. Things like doula services and breastfeeding, and that are really initiated by community members. Our Healthy Women, Healthy Baby program kicked off last year. It's much more focused on quality and outcomes rather than fee-for-service. And so as our healthcare system evolves to population health, we wanted to evolve with that and incentivize our programs for better outcomes. And I think you heard a lot today about statewide engagement. We have such great stakeholders at the table. You heard their voices today, different voices than we had in 2004, 2005, when we started, really bringing us in a different direction. And finally, the work of the Delaware Perinatal Quality Collaborative, which is, it's very different from this work, but there's still a role for hospital quality and make sure that the quality is equal and equitable throughout our state. And Garrett Cole-Morgan leads that work. And thank you, Garrett, for your leadership with that. And yet, despite those successes, as I started with, we have many opportunities. And I will ask the question, how do we achieve equity? And maybe our speakers gave us a path forward to that. And ask the question, have we done enough at the hospital level, at the community level, at the policy level? I think these days in the summit really energizes us for the work forward, but we have to continue to think differently and do more and advocate for change inside and outside the healthcare system. Many of us work within the healthcare system. Most of us now work outside of the healthcare system, and it really is going to take all of us and both sides of that coin to move our work forward. And so a call to action, a few reflections on what we have learned today, or what I've learned from Sonny. This is our destination, or the destination of today. This is where we ended up. I think we learned about the importance of policy, the American Recovery Act and other policies, and moving us forward. This is really high level stuff, but this is where, this is where we need to go. We did not get to our high infant mortality rates over a decade. We got there over years and years of policy, and it's going to take policy really to make that change. To have equitable impact on the greatest number of women, children, and families, we have to ensure effective public policies, programs, and services. That's saying the same thing: policy, policy, policy. We really need to reframe and reclaim our communities through stories. I mean, that what Sonny told us and taught us is just a great lesson. There's a story there from so many people that we need to listen to, and we need to become better listeners. I think collectively we have done that as a group over the past several years. We learned a lot about the importance of structural racism and cultural bias in determining maternal child health outcomes, and really the need to improve these factors as well. Part of our destination today and our learning was to provide quality care for women before, during, and after pregnancy up through 1 year. And it's so happy that our health officials and the medical director of Medicaid was with us today and joined the program and part of the collective voice here in Delaware. It's just great interaction. We learned from many of the speakers and from the video that we have to listen to every woman, every time, every woman, every time. Importantly, inequities are an existential threat. Ed taught us that, and I can't agree more. Inequities are an existential threat. If we don't attack that problem, we are not going to fix the problem. And we have to stop tolerating the intolerable. We have to think differently about how we do QI and what we focus on. I think Karen Scott taught us about a different way of thinking about the hospital level and getting beyond the data. And I'll admit that, even though I started this session with the data. And then lastly, going back to Sonny's story that he opened the talk with, we don't want mothers and babies to die from the cold in our hearts. And I think you felt the warmth in our hearts and the love in our hearts today. That's where we need to go. That's where we need to be. And with that, I'll close. And I want to thank everybody for attending. If anybody's been there 15 years in a row, other than Susan and Garrett and those members of who've been on the consortium, please let me know. I'd love to hear from the people who've attended 15 years in a row. Some people have sent me great texts throughout the day. Thank you. Thank you for attending. The innovation stations will be open for another half hour. We will see you next year, hopefully live and in person. Thank you.